Okay. Good morning, everyone. Please take a seat. Please take a seat. Thank you very much. Good morning, and I hope you all enjoyed the cocktail yesterday evening and the evening in Vienna with so many beautiful places. So today we will have a full day to continue our journey. And our journey today will be on infection prevention and control, antibiotic stewardship, and awareness raising and communication. But we will start the day with a keynote presenting an international perspective. And I'm delighted to welcome Xavier Teles Canavillas. Xavier is a member of the quadripartite working group on youth engagement for AMR. He will talk about essential visibility, how making veterinary work visible changes AMR response. Thank you, Xavier.
Good morning. First of all, thank you so much for this opportunity to talk a bit about what has been my journey so far in my career. And so I've prepared a little presentation for us just any moment now. And so my presentation, so it's focused on essential visibility, which has been something that I have been devoting the early parts of my professional journey. And so we know that AMR is the defining cross-sector health threat of our generation. We know that the science is clear, and we know especially that AMR is something that we can only tackle with a One Health attitude. It is not something we can tackle individually, but we are still disconnected. And my question was always why, ever since I was a student. And that basically formed the thesis for my professional journey, which is that the contribution of veterinarians to public health needs to have this essential visibility. And this visibility, it's truly a barrier. I believe in public health as a whole, when things go well, it's practically invisible, right? Because we cannot see an outbreak that didn't spread, we cannot see a pandemic that never started, we cannot have a food shortage that never reached the supermarket, and so public health in its spirit, it's invisible. And I believe that veterinary public health is one of the most invisible of all. And so when we have work that is invisible, we lack recognition and acknowledgement. And if we lack that recognition and that acknowledgement, what we also have is an undervalued profession. And being in an undervalued profession, what that means is that our contribution doesn't have the resources that it needs, doesn't have the weight, the influence in health policy that it needs to be able to defend its own work and to be able to keep on doing the work it needs to be done. And what this sums up to is basically siloed systems, which are basically the systems that we work in. So systems that live in isolation, that achieve and fail in isolation, and those systems don't allow us to have a coordinated and effective response to AMR, no matter how strong the scientific evidence we have from it. And so, for me, this really opened a two-pronged response to invisibility. The first one with connection, and after that with data, because connection is basically starting the conversation, but then we need to have something meaningful to say, and that is where data comes to play. And so, starting with connection, as a student, we started in the Portuguese Federation of Veterinary Students. We participated in building and founding the National Health Students Forum, basically a forum that gathered students from all health professions, so nutrition, medicine, human medicine, veterinary, pharmacy, psychology, among a lot of others, in order for them to understand the role that, that all of them have in the bigger health scenario. And that was very powerful because when students have this connection and start to do this work and start to learn about other professions, it's way before they crystallize in their professional identity. And so the barriers that we face further down the road aren't set yet. So basically what FNESH has been allowed us to do is plant the seeds to then harvest them later. And we did harvest them with the Young Health Professionals platform further down the road, already graduated. And we started this platform more towards policy and advocacy, knowing that we together could achieve a lot more than separate. And so with that, we started preparing and working on political visions, in this case for the Portuguese government, on how health could be discussed as a whole with all professions on the table, because I believe the table of health is quite long and large enough to fit us all. And from there, I have been also very honored to be integrated into the cohort of the working group on youth engagement in AMR from the quadripartite. And this has been also a very grateful experience, because what this group is basically doing is just trying to tackle all of the best examples that we have found in terms of AMR youth engagement and giving them a global platform integrated within the quadripartite structure. And just to give you an example, because we do not have to participate, of course, in every discussion, but if we are present, we can have something to say. We can learn from each other's mistakes. We can translate knowledge from one area to another. And that is exactly what happens in the Young Health Professionals platform. So just last year, we've presented 5 different action papers to the Portuguese government, focusing from career and work conditions in the National Health Service to health literacy, to One Health. And so this perspective on health really has a political significance, because even though, of course, it's a young health professionals platform, so it combines young associations and representations of young professionals, when we have a common voice is very interesting to the political and policymakers, because basically a lot of the discussion was already made, a lot of the compromises were already identified, and a lot of the strengths and weaknesses have also been identified. And so, but of course, as you know, connection and starting the conversation is not everything, so we need to have something meaningful to say, and that has been the second part of my professional journey, which has been data. And I truly believe that data makes impact visible and makes veterinary work visible. And so when I was just finishing my veterinary degree, I had to do something for my master thesis, and I had these questions in my mind that were, how can we make veterinary work visible? So not only to other professions, but to veterinarians as well, because if they cannot see their value, they cannot pass it on to anybody else. How can we demonstrate with evidence the real value and impact of what veterinarians do daily? And also, how can we give it significance and scrutiny? Because without scrutiny, there isn't any way to be able to improve on the work that veterinarians are doing. And so for these questions, I thought that maybe a good answer would be to try and develop an electronic prescription system that would be able to not only create data, but to give scrutiny, give significance, and most of all, to have also a common voice, a common denominator for all veterinarians. And so I was 23 or 24 years old, and I tried to book a meeting with the Portuguese competent authority, the GAV. I had a presentation and a little PowerPoint, and I was very excited to present, and I told them my ideas, and I had a lot of schematics and graphics to show them. And I did the presentation, and I came back home, and I just thought, this is completely crazy. No one in their right mind is gonna let someone try and do this. But much to my surprise, the Portuguese competent authority said, let's build it, and they were immensely courageous, and I'm very grateful to them for it. And so, with that excitement, we built PEMF, basically the Portuguese electronic prescription system. And from the beginning with PEMF, we had some key objectives. We wanted to cover all kinds of prescriptions, so not only electronic prescriptions, but manual prescriptions as well. We wanted to cover not only prescribed medicines, but also administered medicines and dispensed medicines. We wanted to cover all species, all clinical contexts. We wanted basically to have a system to close the circle completely. And so that is what we did. And with that, we were able also to get clinical context out of these prescriptions, because we have the diseases, the production stage of food-producing animals. We have, if it's a prophylactic or metaphylactic use, cascade, the use of cascade. And so we have a lot of this clinical reasoning present in our data in the electronic prescription system. Another thing that we wanted to do is have supply chain integration. So we wanted to know if a prescribed medicine went up to the pharmacy and was sold, because we needed to know the compliance in order for the data to be significant enough, because we cannot take outcomes of that data if we don't know if that medicine has been effectively at least bought, if not bought and administered, and when and how and by who. And so we integrated also pharmacies, distributors. We integrated all of the chain of medicine, so all of the alterations, all of the market authorization that were granted. Everything is connected in the single system, so that all of the data is related, all of the data is structured, and so we can truly take some insights out of it. And with this system put in place, what we have is records from individual animals to farm records that are very detailed and that have this granular ability, so that we can also have the potential to do targeted interventions. And of course, as well, outcome tracking, as I've spoken. And with having all of this data structured and reliant on what is European data strategies and European controlled data by the EMA, we have this system also prepared for interoperability at the European level, not only functionally, but also in terms of reporting. And that is something that has been also very good in terms of resource use. And just in 2024, so 2 years after the launch of the electronic prescription system, we have already just in the year 2024, sorry, we have 17.1 million animals, food-producing animals, that were treated, more than 1.2 million packages prescribed. On the side of companion animals, more than 235,000 animals treated during the year of 2024. But what really makes us proud is how we can effectively measure things that we weren't able before. So we can see that we have been reducing a lot of the prophylactic use in terms of the use of antimicrobials, especially in swine, is something we can see over the years. We can also see that most prescriptions most antimicrobial prescriptions are in the lowest risk AMEC category. And also, we have been able to use much of this data for targeted interventions by doing disease clusters and by understanding exactly how these diseases are spread, what's their regional context, what's their farm context, among other things. And because we cannot have such a seismic change, right, in the work that veterinarians do without giving something back and without creating value. Because if we are adding another task on top of whatever work clinicians have already to do, we cannot drive adoption. We cannot drive adoption. People are going to resist the system, are going to try and find ways to counteract it, to go around it. And so what we really tried was also to not only bring value as surveillance per se, but also as a tool, a clinical tool that veterinarians can use and that can bring them value and increase their value as health professionals. And so today, in just, I would say, 15 seconds at the point of care, veterinarians can have access to this complete treatment history. So all prescriptions that were prescribed for a given animal, medicines administered, diagnostics that were made, now is something that they can see without any information gaps, without needing to ask the owner or the producer one more time about exactly what happened. They can see and they can recognize some disease patterns that was something that they weren't able to do previously. They can also see how their prescription or how their clinical approach has been, will be effective or no, or at least they can infer from the experience of other vets that came before them and handled something similar. And so with that, we can also compare outcomes. And that is something that we, in an electronic system with big data mindset, can do, is we can extract value from just collecting all of this data together in a structured manner and make it so that this value, it's not only visible to regulators, but also to veterinarians as a whole. And so this, of course, leads to better stewardship and more value to the professional. And currently, what we are now trying to achieve and working on is using this data, using resources like machine learning to create models and develop models that can give us some more insights into the data that we already have. So we are trying to basically create models to predict the risk of zoonotic diseases, such as individual risk variables, but also trying to see what patterns emerge on early disease so that we can have targeted interventions before there is a widespread AMR risk, of course. Another thing that we have here is you can have a time series analysis of patterns of prescription that we can then use to correlate with analysis on antimicrobial resistance and see if we can identify any patterns that we know with a certain degree of certainty that will probably lead to the emergence of some resistance. And also in more of an exploration, let's say, kind of work, trying also to detect patterns that at multiple dimensions that can also help us be more effective and have a better use of our resources. And of course, this means for regulators that we can optimize resources, that we can have early warning systems with risk prediction, and that we can have evidence-based policy interventions, and especially we can have a proactive risk mitigation. And we can truly say it's proactive because we're all under the same platform. And so these insights can go directly into the vet when he's doing a prescription and is choosing a desired antimicrobial. If we have some insight that we can share with him or her, we can basically try and mitigate this risk even before the prescription even has a unique number. And so this is something that also adds value to the veterinarian, improves the clinical outcome, and allows us to have a common understanding of how this data also is used and the value that is created, and also, of course, allows us to have a better adoption rate and a better compliance rate with the prescription system. And so why we need them both together? Because not only because they amplify, but because connection alone is, of course, is important, and case-by-case collaboration works, but we cannot have a widespread success story. We cannot have a widespread behavior change, and we cannot measure collective impact. And so if we cannot measure collective impact, we don't have as strong of an argument for health policy. But if we have data alone, of course, we have that data set and that has its value for certain, but there isn't any demand for this data. And that is a big concern. And so if there isn't a demand, why do we have this data set, right? If we have this power in our hands, but no one is asking for it, nobody is open to it, what's the impact of it, right? And so for me, at least, I believe that only with data and connection, the same as starting a conversation and having something meaningful and impactful to say, we can, only with them together, we can really achieve some transformation. And I believe as scientists that we all have sometimes an attitude towards connection and improving those connections, that it's not real work, or is it not something sometimes that we value immediately, but it is something that opens the door so that when we have meaningful data and when we have meaningful impact, the doors will be open to us for us to share the value that we contribute to public health as a whole. And so in this transformation, we can have the conversation and the thing that is meaningful to say. And this is what I've called essential visibility as a foundation for AMR and this One Health attitude, which is when the work is visible, the work is recognized, is acknowledged, is valued. And if there's valued, collaboration occurs. If we break this cycle that we have now of siloed systems and undervalued professions, we can extract value from other areas that so far have been just living in isolation. And so with this professional dignity, with the evidence-based collaboration, we can truly achieve a behavioral change at scale. And I believe that AMR is actually, of course, a challenge, but it's also an opportunity to really make One Health concrete and something that one day will not be innovative at all, will not be new at all, won't be a buzzword, will just be something that is inherent in any one of us as a collective identity as healthcare providers. And so just to share a bit of this Portuguese experience on my perspective, for us, we now have this unprecedented veterinary data infrastructure. We have more than 2.5 million prescriptions that were prescribed by the electronic system in just this 3-year period, but actually it's turning 4 years old on Saturday. looks like a child, sorry. And we have young professionals that took the challenge and are working across sectors naturally. We have evidence that demonstrates this impact on population health, and we have EU-level interoperability. However, of course, we still have a lot of ongoing work, a lot of challenges, because cross-sector data sharing needs advocacy and needs people to stand up for it. There is still a lot of connections to be made in terms of hierarchies and leadership and policymakers, and of course this kind of scaling truly needs political commitment, and for political commitment, as we know, we need public engagement. So our key lessons, it's basically just we need to build this visibility on all levels, we need connection and data, and organic development, so just taking the step forward is the best lesson, it's the best guidance that we can have. And of course, it takes a lot of time, it takes a lot of effort, it's very hard to break down these silos, it takes a lot of, sometimes even courage to step into rooms where you are absolutely side-eyed, but we need to take that courage for our generation and for the next ones. And so, just to finish, the lay of the land in Portugal, we started from this contribution being invisible to some interesting data points and to having this progressive cross-sector collaboration that we foster and we value very much. And so, just to end, I would like to say that even though I'm a bit idealistic, I am not that naive, and so essential visibility doesn't solve AMR. So sorry for ruining the first 25 minutes of the morning, but yeah, thank you very much. But I'm absolutely certain that without it, we cannot solve AMR. Thank you very much.
Thank you very much. Thanks a lot. Thank you very much, Javier. It's a message of hope, but unless the last slide, but thank you for this message of hope. And you brilliantly illustrated what we said yesterday, is that generating data to generate data is not sufficient, does not mean anything. Things that we are doing must be meaningful. And yesterday we said about surveillance that generating data, it's needed to generate trust. And thank you for this brilliant example you have made in Portuguese, and that illustrates also that when we want something, we can have it. And you know, the EU-JAMRAI 2 spirit is also to exchange best practices. So you did it perfectly, and I think you made some people in the room jealous and engaged to have this in our own country. Thank you very much. And we continue this journey with the next stop about infection prevention and control. Again, a very important topic. You know, preventing infections everywhere, in hospitals, in the community, on farms. It is our first line of defense. And sometimes when you speak to people and you say, but AMR is also infection prevention and control, they say, what? No, yes, it is. It is. And if you do a very good infection prevention and control, you save antibiotics. Prevention is a universal language, from hand hygiene to animal vaccination, from biocide management with the environment to safe surgery. So it's time to turn to infection prevention and control with our expert teams, and I call first on stage Maria Lopez. Thank you, Maria.
Thank you, Marie-Cécile. Hello, everyone. Good morning. My name is Maria Lopez. I'm from ECO, Spain. And on behalf of the JAMRAI IPC colleagues, I will introduce our session. We are thrilled to go through some of our achievements on infection prevention and control across the three sectors: human, animal, and environmental. To begin with, we will show you a 2-minute video presentation to introduce IPC as the first line of defense to prevent antimicrobial resistance. A big thank you to the communication team who produced this video.
Antimicrobial resistance is a complex threat that demands a unified solution across all health sectors, care settings, and countries. A simple yet powerful first line of defense is infection prevention and control, IPC. Every infection we prevent is one less chance for resistant strains to spread and one more chance to preserve the antibiotics we still have. And once antimicrobial resistance has emerged and become prevalent, IPC, more than any other intervention, becomes critical. When treatment options are limited or failing, stopping transmission is often the only way to protect patients, animals, and communities. Supporting IPC means more than producing guidelines or surveillance data. It means sharing best practices, interconnection within sectors and across sectors, organization and countries, so effective solutions and experiences can be shared. A focus on IPC guidelines, tools, skills, training, and knowledge exchange is at the heart of EU-JAMRAI 2. In human health, it is the hand hygiene that stops an outbreak. It's the safe use of personal protective equipment that protects vulnerable patients. In animal health, it is the biosecurity on farms, its vaccination programs, and responsible waste management that prevents outbreaks and reduces the need for antimicrobials. And in our environment, IPC means safeguarding our water and soil from contamination through effective waste treatment. It's about breaking the cycle of transmission that connects us all. But guidelines, tools, and knowledge are not enough. Behavior change science helps us understand why people do what they do and how to address the practical, social, and cultural barriers that so often block good IPC practice. It turns awareness into action and action into habit. In EU-JAMRAI 2, we are connecting the dots. From paper to practice, from the hospital to the farm, we are strengthening the foundations of One Health and creating solutions many can benefit from.
Our work on, Thank you. Our work on IPC shares common objectives among sectors. Together, we focus on standardization, implementation support, and knowledge exchange to create a structured approach in Europe. And now, we're going to present you some selected results and touch upon next steps. I give the floor now to Anne, my colleague from the animal sector. Thank you very much for your attention.
Good morning, everyone. It's my pleasure to be here and to update you on the progress, the insights, and the road ahead in animal health. More specifically, implementing IPC in the animal health sector. Our work is embedded in this core message: harmonizing, strengthening, and enabling IPC in the animal health sector. And it's not only about the technical guidance, but it's also about creating conditions that make IPC doable in practice. Our task also corresponds to the EU Council recommendation, our favorite document I heard yesterday, and more specifically, this recommendation to encourage the advice and the uptake of biosecurity and IPC measures. Over the past 2 years, we have addressed this through evidence and through dialogue, together with our colleagues working on antimicrobial stewardship in the sector. We conducted surveys on IPC tools and IPC guidelines and literature reviews, and we had a wonderful expert workshop last year in Bilbao. And I'd like to give you a little glimpse of that workshop through the following video. Thank you to the wonderful comms team helping us to translate our ideas into this video. So the workshop highlighted many topics, and many of those we've been continuing to work on, but it also highlighted co-creation as a key principle for IPC implementation. And as you can see in our roadmap, this translates in further engagement, not only the engagement between the partners to build upon the evidence generated, but also engagement with the field, with the veterinarians. And to this end, we have organized veterinary focus groups across different member states. So many of our partners, they went into discussion with the veterinarians in the field. And as you can see, we organized these focus groups across diverse fields. Yeah? The animal health sector is very diverse. And so we had these discussions between veterinarians in the animal health sector, food-producing animals, as well as in the companion animal sector. In addition, FEE organized mixed focus group sessions, bringing together veterinarians from different member states around the table to discuss IPC measures and the implementation of it. So far, 129 veterinarians have provided a broad range of perspectives, and more focus groups are currently being organized. So these focus groups are small, structured group discussions moderated by a common set of questions, and we had 4 specific aims in mind for these discussions: to identify infectious diseases relevant to AMR and the use of antimicrobials, discuss different IPC measures, discuss also their implementation barriers, explore veterinarians' attitudes towards the use of antimicrobials and also different preventative measures, and discuss different types of tools and support already available, but maybe also lacking in the field. And we got a lot of information, and I only have a limited time slot. So I will present for you only selected barrier and enabler insights from 2 completely different sectors: the companion animal sector and the pig farming sector. And although completely different in their organization, as you can imagine, across both sectors, 4 major common barrier themes emerged. And bear with me, so we have in there infrastructure and facilities. So often they limit already the IPC implementation, whether it be the lack of space, the lack of isolation and quarantine areas in a clinic or in a farm. Second, we have these economic constraints that IPC competes with time and affordability, and that can range from increased owner costs to also the high upfront investments required from farmers. Third, we had governance and also feasibility challenges that undermine a consistent IPC. And there it was mostly mentioned the lack of enforcement, not only on the farm or on the veterinary clinic, but also beyond, because IPC doesn't stop at the border of the clinic and the farm. And fourth, we had behavioral factors that strongly limit the IPC effectiveness, ranging from an owner non-compliance to prescribing habits of veterinarians, as well as farmer risk aversion. And you hear already that I mentioned a couple of people here. We have the owner, we have the veterinarian, we have the farmer, and we have many more advisors as well. So they all play a role in implementing IPC. For the sectors, we had some specific elements coming up as well. There are existing guidelines. Some more guidelines are being created. They're not always used effectively. There was the call for more screening of multi-drug resistant bacteria. And we have the loss of IPC, the control on IPC beyond the veterinary clinic in the companion animal sector. In the pig farming sector, food-producing animals, we have the huge impact of the market volatility and the prices, of course, in their decisions on preventative measures, as well as how production systems currently are. Some of the current production systems, they just limit or they make it very difficult to implement these preventative measures. But I don't want to bring you a message of doom, because there's a lot of solutions and a lot of enablers that were mentioned by the veterinarians themselves. So what would help to make IPC doable in practice? And I'll present you a lot of information on this slide, but it comes down to this. So let's just start visually. You look at the block there, capacity building and training. So the enablers, they range from strengthening skills and confidence, priority to IPC, in the work of the veterinarians, to owner engagement. And owner engagement, empowering owners through targeted communication. They do have a role in IPC. Repeatedly emphasized was also the need for a clear, harmonized, but adaptable guidance in IPC, alongside implementation tools. And these can range from checklists and hygiene plans to digital support. Access to diagnostics remains very important to reduce the use of antimicrobials. And in addition to that, many veterinarians also mentioned the need for some system-level support with an enhanced public-private collaboration and the importance of data sharing, something that was mentioned already by the keynote speaker, importance of data, as well as our colleagues yesterday with the different surveillance systems. Some of these are directly addressed in our work in EU-JAMRAI 2, and particularly the harmonization of the guidance. For the pig farming sector, there were another couple of central themes that we can call IPC enablers. And a central theme there is aligning economic incentives with prevention. Yeah? Through risk-sharing mechanisms. Prevention also needs to embed it at its source. So from the start, if there's a possibility, involve the veterinarian, involve different advisors in the barn design and in the biosecurity planning of the different stables. Clear and practical IPC guidance was also mentioned, together with a coordinated support and advice. And finally, there is the need to exchange more data, farm-specific data, monitoring data, and also feedback mechanisms that are essential to support not only the veterinarian, but also the farmer to take ownership in IPC. A couple of these elements are, again, directly within the scope of our work with creating IPC guidance and core principles to enhance the IPC implementation in the sector. So taken together, these insights feed into our main output. And our main output here is to create an IPC framework. So having this shared EU-level set of core elements to raise baseline standards in IPC, in the animal health sector, and support consistent implementation. So as shown here, the framework is built by bringing together the evidence, not only from the veterinarians through the focus group discussions, but also from the expert workshops on AMS and IPC measures, as well as the surveys and the literature review. So bringing the evidence together from these different activities, we would like to further develop this framework in terms of a guidance document, and that can serve as a practical tool for different stakeholders to start revising protocols, to start implementing a true IPC program in the sector, and to update national policies and national action plans. So I will close by coming back to this core message. Yeah? Harmonizing. To harmonize, we developed this IPC framework. Look out for it. It should be ready by the end of fall this year, so we can start building the framework together with different stakeholders and organize different peer-to-peer activities. To strengthen, we had these focus group discussions with veterinarians. We will have another AMS IPC expert workshop focusing on skills and competencies required, and also broaden our stakeholder network. And to enable, we support the local IPC activities from different partners, and we will have these group discussions, peer-to-peer activities, in which we look for implementation strategies for the IPC framework as well as the AMS framework. So my colleagues will tell you more about that in the next session. Altogether, this continues, moving IPC in the animal health sector from guidance to action and make it a practical and a very effective pillar in AMR prevention. Thank you all. And I think next up is my colleague focusing on IPC in the environment sector.
Hello, everyone. It's colleagues. Let me see. So we will share some of our results from the work group. Luis, you have to look that way. We will share some results of the group working on IPC in the environmental sector. My name is Roosmarijn Luiken. Oh. And this is my colleague Louis Lucena. We're from University of Limoges and from the RVM. So, as the definition of IPC in the environmental sector was not really existing, at least to our knowledge, we needed a definition to start working in JAMRAI. So how do we define infection prevention and control in the environmental sector as activities that potentially reduce AMR emissions from human and agri-food activities to the environment. And this is in addition to last year, reduce current levels and further spread of AMR in the environment. And here you can see a few examples that we have envisioned from the start that fall under these activities. And I hope you see some similarities with animal and human IPC. So we have worked on a survey to collect information about these activities. And why did we do that? We wanted to provide a first line of evidence of current treatment methods with potential to reduce AMR emissions. While doing that, we wanted to map country stakeholders responsible for these interventions. And we wanted to identify barriers and enablers for their transferability and implementation across countries, and maybe implementation into national action plans. And here we would like to show you some results of our survey. So we are very happy that we have collected 21 examples of IPC interventions in the environment so far from 9 different countries and from many waste streams, also waste streams that we have not envisioned at the start. Wastewater, that was the most the majority of our examples, that was expected. Stormwater, sludge, manure, household waste, medicine waste, plant waste, and other types of interventions that help reduce emissions to the environment. And as you can see, we are dealing here with many different stakeholders. And these are typically all activities that are not belonging to one domain. And these are really interdisciplinary activities. And we must also admit that in our group, not for all these waste streams, we have the expertise, so we need to seek advice from outside our group. So when starting the survey, I'm going to share now a few results. First, those results that we can analyze in an aggregated way. But as you can imagine, most of these interventions are unique, so they need one-on-one interpretation. And at the start, we thought these interventions are probably not aimed at AMR emission. And indeed, when we asked this, the majority wasn't, but also a part was. So that was a surprise to us, but really nice surprise. So if an intervention was not aimed at AMR emissions, or what else was it aimed to reduce, then the most given answers were pathogens and pharmaceuticals. So we also asked, what is the implementation framework of this intervention? And as expected, most of them were on a voluntarily basis. But also a legal obligation. And this is interesting because we asked for interventions that go beyond EU legislation. Of course, we assumed that countries were implementing those interventions. So we asked for interventions on top of this EU legislation. So these legal obligations are national legal obligations, which is very interesting and inspiring. And also we asked about challenges and barriers for the implementation of all these interventions, all the different type of interventions, but also they do share same challenges. And one is lack of resources, which is of course also aligning with a lot of voluntary basis. And also one of them is stakeholder involvement and lack of central coordination. These data need further interpretation and also conversation with the experts on these different waste streams. And now I give the word to my colleague, who will share a bit more positive, the enablers.
Can you hear me? Hello? Can you hear me? Can you hear me now? Yes, okay. So regarding the enablers, so we have identified like the recognition of the need for intervention, which it's related to the fact of increased awareness, the low cost and low maintenance of the solution, which is related also to the sustainability, which is good looking forward, and then past experiences, and then other aspects that we listed in the survey, like political will,
media attention, legal basis, and education. And well, regarding the wastewater treatment, there are many interventions in this survey. This is like a summary slide of all this. So regarding the sources, most of the wastewater sources are urban, municipal, and industry wastewater, also hospital wastewater, and industry wastewater other than pharmacy. Regarding the purposes of these treatments is for safe discharge into the environment, but also for enhancing water reuse for agriculture and crop irrigation, and supporting industrial water reuse. And regarding the treatment techniques, we have from one side the level, so we only focused on advanced treatments. So this is, you see here, the tertiary treatment and or the quaternary treatment, which is targeted toward the so-called chemicals of emerging concern, which includes AMR. So this means that most of the interventions we see here are towards chemicals or contaminants of emerging concern. And regarding the processes, so this most of the interventions are biological processes or biological plus chemicals. And then in the other category, we have some more examples that are very interesting. One is from the Netherlands, focused on reducing AMR in aspergillus by applying treatment in flower bulb waste. Then we have an intervention in Sweden, which has been long-standing for several years, on the safe and effective handling of leftover medicine. This is not specifically aimed at AMR, but indirectly helps a little. And then there is a dashboard going on from the EU Partnership on Animal Health and Welfare, where they identify hotspots of manure emission, well, from AMR emission through livestock manure. And all these results are going to be published next week in a milestone report, but a more in-depth analysis is needed, and it will be published towards the end of the JAMRAI. Looking forward, we have to choose which are the best practices among the survey, which, by the way, is still open, and encourage you to continue reporting. And many aspects to select these best practices have been discussed across different meetings and workshops, and we have decided so far to include, most importantly, the efficiency of the treatment techniques for AMR removal, the multi-purpose benefit across different stakeholders of these interventions, and the feasibility for adoption across countries. And then outside the scope, we would leave for now the economic costs, the circular economic principles, and the level of maturity. And well, we will include in the scope the technical characteristics of the intervention, the governance aspects, the challenges and the enablers, and we need to study how feasible and transferable these best practices are across countries, because it could mean that maybe a country cannot adopt this practice. And we wanted to finish by saying that we have done a very good synergy with the team working on the antimicrobial stewardship in the environment. We are together defining core elements and working on definitions that we will be publishing later this year in a scientific publication. This working group have been identifying target audiences to be trained. They have published a very big chunk of work on needs assessment to analyze knowledge, attitudes, and practices related to AMR. And they have published also a repository of training methods. So together with our work in identifying stakeholders and mapping the country interventions, we will crystallize all this into training methodologies and audiences to be trained in order to adopt these best practices. So we wanted to finish without saying thank you to all the people involved in the making of this survey and the respondents. Thank you very much.
Yes, thank you. And I would like to ask my colleague Anne. We want to have now a Q&A session, and after that, the next two presentations on IPC will be here for you. We have two activities. One is with the use of Mentimeter. We want to show you some dilemmas we experience in the field of IPC. And after that, we have some time for questions from you. So we know that the Wi-Fi is not that good here. So we were wondering how many people can enter Menti at the moment. Because if the majority can, then I think, yeah, we can use it. For those who cannot, let me see how we can involve you. First of all, it's possible after a dilemma to speak up. If you have something that is important to say regarding this dilemma, then please raise your hand, and that's for everyone, also if you have not responded. And I want to say that these dilemmas are, of course, a bit black and white. We know that the reality is more complex, but we want to sort of provoke thinking about this. And for now, please make a decision. This is not, we're not going to record this. We're not going to hold you responsible for this answer. But we just want to see what is happening in this audience. We have some general IPC dilemmas. And we have some more specific for the animal and the environmental domain. And for this, I am not sure we can do the... Can we start the Menti presentation? So the next slide. And then I think you both need... I think it's then.
Oh, can you change? Can you move forward?
Yeah? Okay. I see the photo.
Okay. That's the first. Okay, so the first question is depth versus breadth of IPC actions. Resources rarely allow full IPC optimization everywhere at once. Should IPC initiatives prioritize deep implementation in selected systems, demonstrable impact, or broad minimal level IPC improvements across systems? Wider coverage. Try refreshing, yeah.
We are more than 7, right?
Yeah. Does someone wants to comment on this response? We have quite a clear answer to this. Someone in the audience? I can't see.
No? Well, we move forward.
Okay.
Next question. Regulation versus motivation. So in both sectors, we struggle with IPC uptake, and so to support IPC implementation, should the emphasis be placed on regulatory requirements and standards, so to have a minimum compliance, or incentive support and co-creation, to have this ownership and work towards sustainability? It's
You have to
interesting.
choose.
Can we say both? That's at the core of the dilemmas. You have to choose. But this is also an open floor, so if you'd like to comment,
which one would you
please.
prioritize?
Yeah. Somebody wants to comment on this further?
Can I comment? Because I actually worked in the veterinary and in the environmental domain, and I guess there's also a bit of a difference. I think in the environmental domain, most will be on legal basis. I know that in the veterinary and animal health domain, of course, we hope to support all farmers and veterinarians to really come up with their own plans. So I think there might also be a domain difference in this answer.
So the next question is in the interface between animal and environment, treatment at source versus downstream. Manure can transmit AMR residues across animal and environmental systems. To reduce risk of manure, we should act at source levels by reducing pathogens and residues load at the animal farm level, or downstream by treating manure before application. Which one should we prioritize?
Any strong opinions about manure treatment?
We have a clear answer.
At source, but then another question would be who is going to do this at source? Huh? Yeah, go ahead, Christine. Yeah.
Do we have a mic?
Do we have a...
Not on. Oh, there it is. Okay. Sorry, I have a very ignorant question, so sorry if this is very stupid, but in Norway, manure is used to apply to fields, and this is environmentally... Yeah, but isn't that environmentally a good thing to do? I mean, is... If it has residues, then not. No. Okay. So I just wonder about the environmental implications as well, because if we're going to start to use artificial fertilizers, you know, what's the environmental impact of this? We can't think, you know, just AMR. We have to think broader than, don't we? Or maybe I'm wrong. Sorry, I'm completely ignorant. Sorry, but yeah.
As we have seen, many of the interventions described in the survey are not specifically for AMR, but could tackle still AMR.
I think manure application has many purposes, and also with good purposes, sometimes to enhance the ground needed, could have bad side effects. So I think that's what we're thinking about here. So if you use manure, then there could be these side effects, and that could be the spread of residues, for example, or other pollutants. Does that answer a bit your question?
Well, I just hope we consider the environment too.
We have another question.
Yeah.
I've got a microphone. Hi. Hi, please. For the microphones. Maybe to answer your question as well, it's not rather the decision whether we want to use manure or artificial fertilizers, but how to treat manure such that we can use it responsibly. So it's not that's not the way out. Yeah.
Okay, hi. I'm Lida from NPH Greece. Concerning the dilemma, my question is the how much, the practicality. I mean, how much would it cost to treat it at source, and how much would it cost to treat it downstream? Would we need new facilities? This is the practical issue that I think that politicians always are going to ask in order to decide. So would it be cheaper and more efficient to treat it at source and let us decide later on who is going to do it than to decide do it downstream and need to create infrastructures from scratch?
Yeah, thank you for your comment. I think it's a very valuable one in many of the IPC decisions to take that into account.
We have 2 more minutes. So
yeah, let's move on to another dilemma. Yeah? Okay. Another one? Yeah, theory versus practice. So veterinarians prefer concise, practical tools, but policy and guidelines, they often emphasize also the details. Should IPC guidance prioritize the detailed, comprehensive guidelines or the simple, actionable tools for daily use? Perfect. Tool development. I think I'd like to make a comment on this as well. So simple, actionable tools, definitely yes, but assure they are embedded in evidence and in science, and as such that the users of the tools can find their way to the broader picture and the details as well.
last dilemma?
Yep. So this is about the environment, definitions. The term IPC, infection prevention and control, is typical for human health and should be adapted with another wording for the environmental sector. So I agree, another more appropriate wording is needed for the environment, or I do not agree, it is useful to also use the term IPC. And I think in the animal health workshop, you agree that to use the IPC term instead of biosecurity, right?
We had a whole morning discussion on what is veterinary IPC, because I think we all agree that we cannot just copy-paste from the human sector. So I think it's a challenge both sectors face.
Does anybody want to have a last comment on this dilemma before we go on to the Q&A? Oh, no Q&A. Okay. So this is your chance to speak up or ask a question. Does anybody want to say something about this dilemma or ask one last question?
Hi, yeah, I would like to ask a question. What would be, because infection prevention control doesn't really seem to fit that easily with the environmental sector, but I can understand why you would want to use it to fit in with the One Health approach. But what would be an alternative that would fit more nicely in the environment sector?
I have no alternatives ready, to be honest. For now, what we see is that it's a working area within JAMRAI, where, as you saw, we collect many activities that are not new. Those are existing activities, and they now come together in this work around IPC. And we are currently discussing with the stewardship colleagues, should we indeed have this common definition or change it. But so no, I'm not sorry, I have not yet an alternative, but we're thinking about it. Do you? Yeah. Do you already thinking about something?
No, but I mean, it just strikes me that I'm wondering what gets infected. And so it gives me a lot of questions. I'm not an expert in the area. And I also think from a communications perspective, to reach the relevant target audiences, maybe you need to have a terminology that they can relate to, that makes sense for them. So I think it's a really important discussion.
Yeah, and that's a very good point you raise here, is that it also maybe depends on the audience you're talking to. So it might help a medical doctor if we say, okay, these are the similarities with IPC, reducing spread, for example. But if we talk to the waste managers, it might be very confusing to talk about this and use other wording. So that's a very good point, yes. We have to, it's Ricardo, but we have to move on. Yeah.
No, expand a little bit more on that last part, because I think that the environment plays a role in the infection prevention and control of humans and animals, in the sense that, sorry? Short?
Yeah. Yes.
Okay, yeah, in the sense that consuming raw vegetables, drinking contaminated waters, or bathing in contaminated waters is infection in humans, or putting animals in contaminated grasslands that have been manured too early and without any precaution. It's direct IPC for humans and animals, and then we can also expand from that point to try to reduce emission sources. Sorry.
Yeah, thank you for that last comment. Thank you all for your contributions.
Thank you.
We have here time to close, like, in our eyes. Okay, thank you very much.
Thank you.
So, if we could get back to the slides. Oh. Yes, so we're going to start the IPC in human activities, and because we have so many different tasks and activities going on, it's going to be quite quick overview. So one of the things we've been doing is an evaluation report on the IPC core competency technical document from ECDC, which we released at the end of December last year. And the goal with that assessment was to see whether the existing European framework kind of fits the needs of today, because that document was from 2013. So what we've done is gather feedback and opinions from partners that are part of EU-JAMRAI. As you can see, like, we have 31 institutions from 22 countries who's answered that questionnaire, and also an advisory board with IPC experts. And let me just do this. So we don't have time to go over the key results today, but I would highly recommend anyone reads our report. We have recommendations on what to do and changes. But one of the important things we learned as well, the framework has stood the test of time. There's a chance. Oh, that went quite loud. There's a challenge to translate it into everyday practice at local levels. So what we've thought about, what's next? And what we've done to bridge this gap is we've been working on a self-assessment tool that could be a companion tool to this kind of technical documents that could help IPC professionals and leadership take it into practice. And the idea with our tool is to help organizations and individuals assess the existing skills, identify gaps, and priority competency development in more of a systematic way. We have designed this tool to be flexible and scalable, so it can be adapted to different healthcare settings and national context. The idea isn't it's a one-size-fits-all tool. It needs to be adapted to the country setting. And this tool will come out in a few months or so on the JAMRAI website, and this is kind of our solution, our ideas of how to fix this challenge that is from going from like technical, very evidence-based documents to how to implement them to real-life practice. So we were planning on doing a Mentimeter. We've just decided to kind of skip it. So, so we will just move on. So my colleague Asha will come on stage now.
Okay, hello everybody. My name is Asha Kuno, and I'm from SSI Denmark, and I'm going to present very briefly the content of our peer-to-peer program so far. So in our tasks within IPC Human Health, we have a great focus on peer-to-peer exchange and exchange of best practices and getting into contact and dialogue with IPC European experts. So now just try to find the presentation. Okay, so we are developing the peer-to-peer program in human IPC health with the UKIC, the European Committee on Infection Control, being a part of ESCMID. And our target groups are not only JAMRAI partners, but all IPC professionals and IPC frontline personnel in the European region. So we believe that need-based support will have the greatest impact, and before getting started with our peer-to-peer program, we carried out a needs assessment survey and tried to base our different activities within the program based on this survey. So by now we have rolled out a number of actions. During 2025, we have started a series of webinars on specific topics, and the recordings of all these webinars so far are to be found at the UKIC YouTube channel. And to get to know our partners, which we have 60 of in our work package, we early 25 we started to carry out one-to-one meetings with all of them to get to know their plans for what they would like to implement, and how this their project is connected to the national action plans, and also what are their specific needs to carry out their project. And we are almost finished carrying out all the one-to-one meetings, but we'll start the second round in February, March this year. Also, within UKIC website, they have started the IPC Nurses Corner for interactive exchange and takeaways for action. And we are also piloting a Q&A hub within the teams, but we plan to work on a more interactive and sustainable solution. So other activities is that we are collecting European peer-to-peer local events. So if you know about one event which is accessible to other people, you can click on the QR code, maybe not now, but it's also to be found in the JAMRAI webpage, and add your event to the list, and the overview will be displayed at the UKIC website. So one more great offer we have is that every frontline IPC personnel can apply for an individual online meeting with an IPC expert. So this is for free. So it only takes you to scan the code and fill in the form, and the expert's actually waiting to get in contact whoever needs this advice. The offer is in particular directed to more isolated professionals who may not be able to interact locally with an IPC professional. So please help us to spread this information in your national and local IPC societies and networks. So what is coming next? We are now going to focus more on peer-to-peer activities linking AMS and IPC with our AMS colleagues within the JAMRAI project. We are starting up in the beginning of February virtual roundtables with direct exchange between peers and experts in a number of different topics. And we are also going to plan for focus groups on specific topics and observerships. So the overview of all our activities is to be found on the JAMRAI 2 webpage, UKIC Education Activities webpage, and we are looking forward to seeing many more of you in our continued peer-to-peer activities. But if you want to know more, please come and talk to us in the information corner during the breaks today. Actually, I think that was it. Let me see. Yes, so next.
Hi again, and now we will be moving on to the efforts made regarding building the evidence base for harmonized EU IPC practices. First, I would like to thank the ECDC colleagues who guided us and helped us through these tasks. First, we undertook a systematic review on diagnostic stewardship in blood cultures. The objective of this systematic review was to gather the most up-to-date evidence-based recommendations on blood culture practices. Among 2,440 records we screened, 17 guidelines, consensus documents, and systematic review were finally included and analyzed. Our ultimate goal with this review was to ensure consistent, harmonized, and high-quality diagnostic practices across Europe, improving patient safety and enhancing the containment of AMR. And what were the key findings? The testing of the blood cultures should be reserved only for patients with clinical suspicion of sepsis and bacteremia and discouraged for low-yield scenarios. The blood volume has to be from 20 to 30 milliliters of blood per set and have to be extracted before antibiotic administration when feasible. For most cases, a single venipuncture provides equivalent diagnostic value and lower contamination risk than multiple venipunctures. And for skin antisepsis, the use of 2% chlorhexidine in 70% alcohol remains the gold standard. A blood culture contamination rate of 1% is a critical and achievable quality measure according to the CDC when good practices are followed. This reduces false positives, antibiotic treatment, and costs. And also, while rapid molecular assays are valuable after a blood culture is positive, they cannot replace conventional blood cultures as the gold standard. And moving on, we also conducted a dual-track benchmarking of European IPC practices. First, we undertook a comprehensive review and updated of the ECDC directory with national and international guidelines. We are very happy to announce that the 30 JAMRAI countries contributed with their national IPC guidelines. And this results and ensures a clear overview of the existing guidance landscape to ensure that the new EU guidelines are built on a complete understanding of current European practices. These guidelines we found have already been sent to the ECDC, so they will update it in their webpage. And also, in parallel, we focused on benchmarking healthcare-associated infection surveillance data. And this work was driven by a clear European priority, that is to harmonize the definitions in line with the ECDC standards, enabling a better interpretation of surveillance data. To that end, we mapped European surveillance systems that collected healthcare-associated infection data and distributed a questionnaire to assess the adoption of ECDC's case definitions. The result of this analysis is a clear overview of the current harmonization level of healthcare-associated infection reporting, pinpointing areas for alignment to enable cross-border benchmarking and for a faster and better outbreak detection across member states. Also, making sure that country-specific contexts are well understood when taking a look at EU-wide data. And we also had a Menti ready, but we are cutting off as well, because we have to give you more time to have a Q&A to ask us about our task, our achievements, or even next steps. So I will be leaving the floor to Fortunato D'Ancona from Istituto Superiore di Sanità, who is not actually here, but is joining online. So I hope everything is ready up there, but I leave the floor to him virtually.
Thank you. Thank you, Maria. I'm very sorry to not be there. I will speak about the IPC implementation, especially in support transforming policy and tools in practice. So we have three areas. Digitalization is one of the new pillars of action to combat AMR and improve infection prevention and control. Sorry, I will share my slide because I think that I have to do, looking at the screen. Yes. So the availability of data is very crucial for action, monitoring, and changing strategies. Furthermore, it's also important to share experience from pilot projects to strengthen good practice and inspire other partners to implement similar activities in different geographical contexts. Then we also have a new, we are creating a new platform inside, designed by Istituto Superiore di Sanità in Italy, that is one of these pilot projects that we intend to use to provide to all the partners partners with wider support in the area of governance of IPC. And now more details about what I said. So our result for a week for a digital tool, we conducted a survey and collect information from 16 countries, and they sent a structured description that fits in a repository that is available on EU-JAMRAI cloud team. You can find the folder using the QR code in the slide, maybe later. But our aim is to make it available on public EU-JAMRAI website very soon. This repository provides a practical, ready-to-use resource for national and facility IPC programs. With the same objective of contributing to this dissemination of good practice, the Italian National Institute of Health collected also information from participating countries on which pilot project they are implementing in their context, and whether they are using a specific tool for IPC intervention. We are monitoring 19 projects in our repository. Again, you can see the QR code, and later in the next weeks, we will make this information available on the public EU-JAMRAI website. We will keep updated this repository until the end of the EU-JAMRAI project. Finally, a brief description of the digital tool Insight that we are developing. This is for all the partners and institutions that wants to use. Probably it will be ready by 2027. Based on the standard WHO IPCAF, that is a framework that is used to assess how well infection prevention and control programs are implemented in the healthcare facilities. We want to facilitate the activity of analysis and the use of IPCAF, aggregating questionnaires of different facilities. So it is a tool for manager that overview more facilities. The first working demo will be presented in the next workshop in Rome, that it will be held in March, and the system, as I said, will be available to all the EU-JAMRAI partners in 2027. So you can see a sort of continuous implementation cycle. We have tools, we have implementation of tools and pilots, and Insight is one of these. So we are trying to push changes using new instrument. I would like to say thank you very much to all the partners that are collaborating to the area of IPC. And now I have to leave the stage to Michael Borg and Vivi Eskelinen for another important area, that is behavioral change.
Whoa. Okay, good morning, everyone. I know we are keeping you from your coffee, so we will try to be as quick as we can, but we really wanted to go through the process that we are using in JAMRAI 7.4, in other words, behavior change in IPC. Now, let's wait. So why do we need behavior change in IPC? Well, simply because most of the healthcare-associated infections in our healthcare institutions, especially those caused by antimicrobial-resistant organisms, happen because of inappropriate patient care practices. And if we want to improve IPC, that is what we have to address. We have to address those behaviors. And to do so, we need to learn from behavior science because, to be honest, we're not that good at that. And arguably, at the moment, the most widely used model for behavior change is the COM-B model, which looks at behavior as the result of three key components. Capability, in other words, the ability of a person to do that behavior, whether it is the physical strength and stamina or else the knowledge and skills. The opportunity, in other words, the system, does the system provide physical sustenance of that behavior through time, resources, and tools, and critically the social opportunity, in other words, the organizational culture and social norms. And then finally, is the individual motivated to do the behavior through both reflection as well as habits and emotions. And the first step that we went through in line with the COM-B sequence is to identify the target behavior. And each of our 13 partners, as you can see, throughout Europe, north to south, east to west, have identified a behavior that they are addressing. And in COM-B, behaviors have a very strict definition. Not surprising, with IPC, the majority of those behaviors relate to hand hygiene, specifically moment one, in other words, application of alcohol hand rub before patient contact. That's a behavior. But others are looking at other things, such as appropriate glove use, preventative care for patients, perioperative prophylaxis, management of invasive devices such as urinary catheters, and active identification and detection of MDRO carriers coming into hospital. And then once you have established your target behavior, the next step in COM-B is to understand that behavior. In other words, look, as we have heard in other presentations, for the enablers and especially the barriers. And this is what we have supported the partners in. So together with our colleagues at the Finnish Institute of Public Health, we have developed a flexible tool, a template based on the theoretical domains framework that then the partners could adapt for their own specific behavior. And through this template, they could then identify priority behaviors and group them into those 6 COM-B domains that I mentioned already. And because it was a common template, we could then look across the countries and see whether there were any overarching barriers in each of these domains. And we've had some interesting results. So in terms of psychological capability, this was not the major barrier. Indeed, most of the respondents said that they knew how to do the respective behavior, that they had guidelines to do it, and they had received some level of training. Of course, there's always room for improvement, but it's mainly in refining and applying rather than starting from zero. On the other hand, opportunity was a massive issue. Across the spectrum of all the partners from Europe, time and workload stood out immensely, with respondents saying over and over again, it is a big issue because of our workload, because of competing tasks, and lack of staff. In addition, the environmental setup, the physical opportunity, is not exactly conducive with infection prevention and control, very often with suboptimal placement and reliability of resources, lack of easy access to guidance, and critically, lack of built-in prompts to allow IPC to be done on a day-to-day basis. So basically, it's a question of system dysfunction, which then makes correct IPC practices difficult to achieve. And the other aspect of opportunity is, of course, the social opportunity. And here, there are almost bigger barriers, where, again, across the board, the feedback was, listen, where we work, for all the nice words, AMR is not a real priority. It is not embedded in the organizational culture, and other clinical processes and outcomes are seen as more important. And when we look at our leadership, yes, they talk a nice talk, but very often rarely walk the talk. So there's lack of emphasis by managers Nice commitments rarely translated into genuine support, and as a result, social factors normalize unsafe and non-compliant IPC behavior. And then finally, in terms of motivation, again, the motivation is often there. Staff, respondents agreed that IPC is important for patient safety, it should be done, and it was their responsibility to do it. But, and that's the big but, adherence is often perceived as unrealistic because of those opportunity issues that I mentioned in relation to workload and organizational conditions. And in terms of automatic motivation, this is weak because IPC behavior as a result of all these barriers is not ingrained or habitual, and therefore that's what suffers first. So when staff are tired or overloaded, the first thing to go out of the window is correct IPC. So this is where we have got to. Now our next step over the next 18 months is to actually identify the interventions at each of these partners and implement them to see if we can get an improvement on that behavior. And with this, I will move to Vicky and ask her to continue this presentation.
Yes. So, we will be brave and try the Menti now. So, I will put the next slide, and please get the QR code, and I will then, ask you the question, and I hope you've been listening to Michael very carefully here now. The identified IPC barriers would be effectively addressed if staff had better training, clearer guidelines, and more surveillance, audit, data feedback. Strongly agree, agree, no opinion, disagree, or strongly disagree. You get some time to think.
And hopefully see the Menti.
More question, do you have a Menti code?
Yeah, there is. Would you like to go back?
Okay, let's do it and get back to the past, and I will ask you guys now.
Forget the Menti.
To maybe forget the Menti, or wait for the results of the Menti, and we'll see if you're brave in the audience to raise your hand when we look at the question, the identified IPC barriers would be effectively addressed if staff had better training, clearer guidelines, and more surveillance or audit data feedback. Do you agree? Please raise your hands if you agree, strongly or moderately strongly.
There's not one single hand.
Some
well, there are two hands at the back.
I see.
Yeah, 3, 4, 5. See? So this is agree, okay? So if you think that those barriers we showed can be addressed by improved surveillance, education, and feedback, raise your hand. No, but I have to see the hands. All right, okay, all right.
And now we move to disagree, or strongly disagree. Be brave.
Okay.
There will be no consequences.
It's definitely majority.
Yeah. Okay, because I can't also see you from here, so.
Let's move on.
Yeah, what we can see, or what I could see, was about half and half, maybe. And if we could now get back to the presentation, please, so we can talk about why actually the disagree group, in our opinion, was correct. So actually, more guidelines, education, and surveillance are unlikely to make a major difference. And that is because staff in most countries, as Michael just mentioned, have high levels of knowledge and positive attitudes, yet the behaviors remain inconsistent. The most identified COMBI barriers that we had were really much about time, workflow, norms, and habits. And as Michael mentioned before, so many of the staff around Europe mentioned the high level of workload and stress, and also hierarchical differences within their units, for example, between doctors and nurses. So if we move on to an intervention that targets education, that can actually have more negative consequences for the behavior, because if the staff report the barriers to be more about time and workflow related aspects, it can cause frustration, blame, and maybe a bit of feedback fatigue. So if we get a concrete example from hand hygiene, which is one of the most popular behaviors across our countries, the environment and workflow do not reliably prompt or facilitate hand hygiene. And as Michael mentioned, hand hygiene is genuinely not supported by culture or leadership or deemed to be essential. So walk the walk and talk the talk. Hand hygiene is often framed as more of a self-protection rather than maybe patient safety, or because of a management says so, and seen as difficult to apply under real-life conditions. And it is not an ingrained habit, and it is easily forgotten when under a lot of work pressure. We were going to have a poll, but we're not going to do that now, so I'm going to just move on to talk about the different interventions we could use for a hand hygiene intervention. So the evidence suggests that the best way to target hand hygiene is actually mandatory personal sensors. It's about real-time, in-the-moment prompting, monitoring, showing the biggest gains overall in the quantitative synthesis. But of course, there are some differences depending on the device design. Second best option is hospital hand hygiene targets plus accountability for persistent poor compliance, which targets social opportunities. Then third is more accessible alcohol-based hand rub dispensers, targeting physical opportunity. And only fourth is a workshop on the World Health Organization's 5 moments and a correct technique, targeting psychological capability, coming back to education alone not being enough when we actually want to change behavior. And last would be ward posters on hand hygiene about safe patient care, because as we know, we are usually not very attentive to these kind of posters around us. So in the next phase, it looks very much like when we start looking at the interventions, we really need to look into targeting opportunities, especially social opportunities, and automatic motivation through environmental restructuring, modeling, and enablement, for example, better workflows. And now I leave it to Michael to wrap this all up.
Thank you, Vivi. So just to conclude, so basically, we weren't all that surprised, but because we speak to so many people in these types of meetings, but I think this shows that the issues are pretty much across the board, and the issues are, as we've already mentioned, very often related to opportunities, especially the challenges in relation to time, in relation to work pressures, in relation to dysfunctional systems. At least from a positive perspective, we've seen and we have identified that psychological capability, knowledge, skills, as well as reflective motivation are not major impediments, but of course, they have this background of the opportunity issues. So indeed, most staff know what to do. They believe IPC is important, but they have these challenges. So as Vivi mentioned, just focusing on education and surveillance alone, we're not saying that these are not needed, but on their own, they are unlikely to make an effect because the main problems lie in automatic motivation and social opportunity, in habit formation and organizational culture. And as a result of this, we need to have a multimodal behavior intervention whenever we are doing IPC. And as Vivi said, what we'll be focusing on over the next 18 months will be especially environmental restructuring, enablement, modeling, and incentives and accountability. And with that, I would like to thank all the partners who are working with us in 7.4, and thank you on behalf of Vivi as well for your attention. Thank you very much.
Thank you.
Now we will be having a very brief Q&A because we passed the time. But please share with us your comments, your suggestions. And there's a question there, Diamantis? I don't know.
Thank you so much.
I do have it. Sorry, Diamantis. I do have the micro. Thank you very much for your interesting presentation. I would like to discuss a topic because I was surprised in one of your presentations where you identify the needs, the priority needs for IPC teams. In that survey, one of the 5 topics identified was antibiotic prophylaxis. And actually, we all agree that collaboration between IPC and AMS teams is key. But I think it might also, like for antibiotic prophylaxis topic, it's a key priority for AMS teams, which deserve specific profiles. And in some countries, the development and implementation of AMS programs and AMS teams might be really challenging. While I think in the development of IPC teams, it's already a way forward. So I was wondering if you discussed this overlap and on a structural point of view, if you have any discussion on that topic.
No, it's like general. Then I can maybe go in. And we are encouraged by the coordination team and for the JAMRAI to close collaborate with our team in AMS that we'll be presenting right now. But we haven't focused on what you suggested. We are actually working currently in our separated tasks. But actually, for the next 2 years, my team from the 7.1.2 will start working with AMS in a set of indicators for a structure and framework, and maybe we can next year answer your question. And sorry. And we just have time for one more question. I think Diamantis was first.
Yeah, it works now. Thank you so much. So first of all, thank you for all the very nice collaboration. Yes. No, these past 2 years, I think it has been very fruitful. And I have two very quick questions. So the first one, whether the self-assessment tool will include the newly competencies. And the second question is whether UKIC would be happy to carry on with hosting this peer-to-peer work. Thank you.
Yes, about the SAS question you are asking, the very brief answer is, I think I can say yes. I'm just looking at my colleague Anne. Yeah, it will include some of the results from our evaluation report. Yes, it will. And your second question was about
whether UKIC will carry on with
the peer-to-peer program. Actually, we have not discussed in detail, but most of all our peer-to-peer activities will also be found at the UKIC webpage. So we plan to make it sustainable that our activities will continue in some version at the UKIC webpage, within UKIC after the JAMRAI project. But of course, we need to discuss more with UKIC before I can just say that we'll do it all. And there, just one comment to the question before about the AMS collaborations, that we will also focus on the AMS IPC cooperation for the peer-to-peer activities. That's what's coming next. So we are aware of the issues there.
Thank you very much. I'm afraid we have no time left for more questions, but please approach to us if you have any further comment. And also take in consideration, we will have an interactive corner today, I think.
We have actually, in both coffee breaks, we have an information corner where you can come and ask questions about the peer-to-peer program or just any IPC question you might have. Thank you.
I had some closing remarks, but I can leave. Oh, I'm sorry. Okay, no problem.
Bon, can you hear me? Yes. Whew. Here we are. So this is the networking break. I'm sorry it will be shorter than previously scheduled as we are already 6 minutes late. So just to let you know that there is coffee at this level just out of the side. But also if you want to do sports very quickly because we have to be back at 11:25, there is also coffee upstairs when you had lunch and cocktail yesterday. And you can visit behind me the info corners, IPC mentorships and pilots, surveillance and country engagement. So please be back at 11:25. Thank you very much. Please, we can go back to the next stop. And our next stop is about antibiotic stewardship. And stewardship means responsibility. Doctors, pharmacists, veterinarians, microbiologists, all making informed choices, guided by diagnostics and data. It's not about saying no antibiotics, but about saying yes to the right antibiotics in the right dose with the right administration mode for the right duration to the right patients. Stewardship programs in hospital improved patients' outcomes. On farms, alternative to antibiotics are transforming veterinary practice. So welcome Lida Politi and the team reporting on antimicrobial stewardship. And please, all the team, when you speak, stay here. Thank you.
Hello, everyone. I am Lida Politi. I'm from the National Public Health Organization in Greece. Antimicrobial stewardship is a central pillar of the EU-JAMRAI 2 project, and it is a key priority for member states in addressing antimicrobial resistance through a One Health approach. Within this project, we aim to strengthen antimicrobial stewardship capacities across human, animal, and environmental sectors, while directly supporting countries in the development and updating of their national action plans on AMR. Our work is structured around a very clear logic. First, building a strong evidence base. Second, translating this evidence into shared frameworks and tools. And third, supporting implementation in real-world settings. This session is structured and organized to reflect that logic and to present how the different tasks contribute to a coherent One Health AMS approach. Before moving into the individual presentations, however, it is very important to briefly highlight what has already been delivered. Over the first phase of the project, we focused on building solid foundations for antimicrobial stewardship across sectors. This started with extensive evidence gathering through surveys and literature reviews covering AMS in human health, in animal health and the environment, as well as behavior change. This work has allowed us to identify key barriers and drivers for antimicrobial stewardship implementation and better understand where countries share common challenges, face common challenges, and where solutions can be shared. In parallel, we invested strongly in connecting countries and professionals through workshops and exchanges, creating the basis for collaboration and mutual learning. These foundations are now being translated into common frameworks, guidance, and practical tools, and these you will all find and hear in the presentations that follow. I would like, at this point, for our colleagues in 6.4, the behavioral change, to join us. Thank you. Can I have the first slide, please? Hello from me. My name is Katerina Iliopoulou. I am from the National Public Health Organization in Athens, Greece, and today, along with my partner, Josera, we are going to present the progress of 6.4 working package, which is about antimicrobial stewardship, which is about behavioral change strategies in antimicrobial stewardship. Can I have the first slide, please? So the aim of 6.4 is to enable healthcare professionals to design and implement behavioral science-informed interventions, which means to make behavioral science accessible to AMS teams. Antibiotic prescribing is a behavior, and in order to improve prescribing, we need to change behaviors that leads to overuse or misuse of antibiotics. It was heard before that we have education, we have guidelines in AMS, we know that they both work, however, they are not simply enough,
because prescribing problem is not a knowledge problem, it's a behavioral problem. We also know that there is a lot of variability in prescribing practices amongst clinicians, across departments and across hospitals. However, we have these behavioral determinants or factors can explain this variability in practice. And what it makes more complex in prescribing behavior is that it's influenced by context, because context matters. What it works in one, for example, primary care in Germany may not work in another setting in Spain. So the approach, one size fits all, fails because we know that healthcare professionals and healthcare systems are fundamentally different. But we have good news. We have behavioral change frameworks, theories, and models in our hands, which allow us to diagnose why professionals prescribe as they do, and to design targeted interventions that stick in practice. But the paradox is that although we have this knowledge in our hands, behavioral science is largely underused in AMS interventions. 6.4, briefly I'm going to tell you, has 4 subtasks. 6.41 is about selecting the best fit behavioral change model in AMS. Subtask 6.42, it's about developing an AI-assisted intervention design platform. 6.43 is about developing and piloting, testing an online scalable training program for AMS interventions. And 6.44 is about designing interventions for for prioritized AMS behaviors. The first subtask, 6.41, we selected the COMBI model, which was very well described from the partners of 7.4. We developed a report which completed in December 2025. Why we selected COMBI? First of all, there is a substantial empirical support. COMBI 2 is about to be published soon. COMBI is a comprehensive diagnostic hub which allows to identify context-informed prescribing behavioral determinants. It's broad and flexible, which means that it can be used with other more detailed frameworks like the theoretical domains framework, and this adds granularity for intervention design and evaluation. It's adaptable across complex levels and audiences. It has global endorsement. It has been used by World Health Organization in the TAP program. And finally, it is aligned with 7.4 activities, and this enhances JAMRAI's impact in adopting behavioral science in AMS. José, the floor is yours.
Thank you, Caterina. I'm José Ramón Paño. I'm infectious disease physician at Aragon Healthcare Service. Aragon is a region in Spain. And as Caterina said, context matter a lot in AMS and in behavior change. So before diving deep into the next subtask, we wanted to better understand the context of AMS in human health in the EU. So jointly with task 6.1, we developed a questionnaire to try to explore 2 aspects. One is how is AMS organized across countries and in different healthcare settings, and in the second is what is the actual knowledge and expertise on behavior change through among AMS experts. So we developed we just performed this survey, and we found a couple interesting things, which, by the way, were expected, but it's important to see them in written. Is that the level? There were differences across countries, significant difference, organizational difference across countries, and regarding the resources, and also and also regarding the settings. So how they self-consider every country prepared for AMS in the different settings. The hospital was the best prepared, followed by primary care and long-term care facilities. I mean, AMS is quite less developed. And regarding the behavior change, there was a universal need and ask for more education and support. And I mean, this was universal. So this fully justifies the next steps of our soft stacks. One is to provide a comprehensive training program that is broadly accessible for AMS. And second, we need to make behavior change easy to AMS stewards. So they need tools. And Katerina, please.
The next slide. I don't have much to share with you about 6.43 because we've just started. Our first meeting was held last Monday. We have in our group 18 participants from 8 countries. The experts have moderate to extensive experience in AMS, development and evaluation of training programs, behavioral science, and the co-design approach. We agreed that we have to utilize a co-design approach throughout the development of the content of the program. We consider that we may need to target all participants in hospitals, primary care, and long-term care facilities. And something that is missing from this slide, that we aim to utilize the digital training resources which have been posted in JAMRAI's website. Next steps is to identify our potential users, the content, how to evaluate its impact, and the level of content's depth. We aim to develop the first demo by January 2027.
And then the tools, because how can we help AMS antimicrobial stewards to adopt behavior change for intervention, design, and implementation? And you know, the AI boom just started in November 2022, and it became clear to us that AI could be a tool that could boost all our activities. So what we decided in this task is that the tools to provide to AMS stewards should be AI-based, and we wanted to provide tools that guide AMS stewards into this process, the COMBI process adapted to AMS. So finally, working with engineers in our group, we decided, I mean, we've been discussing on the architecture of this AI-based tool. And we decided that the best way to go is through a multi-agent system that guides AMS stewards, which are not experts in behavior change, in this process, the COMBI process. So I will show you how is the architecture of our prototype. So we have a central agent, which we call orchestrator. That's the one who guides through all the process to the user. The user is the AMS steward. And this orchestrator can call to one of each of these 5 agents. These 5 agents replicate the process that has been previously described by 7.4. We have a behavior science systems analyst. We have a barrier masters, which explores the barriers of the previous behavior. We have an intervention matcher, who helps to match the barrier and the best potential interventions. Then we have the implementation architect that helps to implement the interventions that have been chosen. And finally, we have an agent that will help the teams to choose the best way to evaluate the impact of the intervention that they design. So we try to follow the COMBI process. And each of these agents is composed by core instructions on what is the role and the personality and other features that explain how it has to interact with the user. And apart from that, they have an associated knowledge base on behavior change, knowledge base on AMS, knowledge base on interview, knowledge base on that complements these instructions. And they are integrated in a single platform. And okay, we have Session Sherpa. Session Sherpa is not in the process. It can be called throughout the process. If you want to build consensus online, on-site, it helps you with the sessions that you have to do grouping. And this is a video, but I don't know if it will work. You see the orchestrator in the middle, and the orchestrator calls the behavior system analyst. The behavior system analyst can respond to the orchestrator or can follow up to the barrier master, to the intervention. You see how it works? To the intervention matcher, it follows the process. Okay, it's the same process. That's it. And we are building, it's very important for us, how the user experience. We have to make this easy and adapted to the flow of a person who can have different expertise. And we want to create, what we are doing now is to assemble this technical platform into an interface that is easy to use, that is institution, also AKA team-based account, and it's project-oriented. You see, it should be to the left, it's the registration. On the second is how an individual user of a team sees the application. There are, in the lower part, the projects. ICU de-escalation is a project with several conversations. Surgical prophylaxis optimization could be another project. It's linked to the institution. And finally, on the right is how every chat works. Which agent is participating in the chat, who is called, and there is a summary. So it pretends to be a specialized multi-agent chatbots to support teams to build interventions. And this is the architecture, but which brain are we going to use? And this is very important. Which LLM are we going to use? And this is very important for two reasons. We want to use a high-performance LLM, but we need to build a sustainable tool. And I will tell you. We developed conjointly with AMS Drive 30 case scenarios. Some were clinical and some were purely AMS organizational. And they were mapped to the core SMIT competencies for AMS and antimicrobial prescribing with low, middle, and difficult level. And we scored how they perform in general, the quality of the response to these scenarios. And then we also wanted to flag safety and fabrication. And we built traps. We just wrote the scenarios inviting to fabricate, no? And this is more or less the response that we had. They were blindly assessed by humans, I have to say that. And this is how they ranked in the quality score. And best is not GPT. That's one. Okay, good. It's just 2 more slides. And the best was Claude Sonnet. And if you see most commercial LLMs, which are less sustainable because you have to pay for them, they perform better than the overall open source systems. So we are planning to have 2 prototypes, one with the best commercial LLM and one with the best open source LLM, because sustainability is important for us. And you can see that the difference between one and the other. And also it was very interesting that with a very simple incentivation prompt, the performance improved significantly. If you do well, you will be hired in this AMS, and you show the scenario, the performance was better. So it was very cheap to increase the performance of the LLMs. And the last subtask, this is the last slide, and it has to be coordinated with education, and it has to be coordinated with the toolkit. We want to, what we are planning is to organize a co-design workshop. It's very limited size, in order to build blueprint intervention for the most priority, for the most important behaviors, for the most relevant problems on antimicrobial prescribing in hospitals and primary care. We will need to choose 5. And during those 2.5 days, 2 teams will follow the COMBI process. One will use the AI toolkit and the other one won't use it. So at the end, we want to have a blueprint adaptable intervention because the blueprint needs to be adaptable to different contexts, but we will also test, pilot test, how the toolkit works in real life. And basically, this is what we are planning to do in 6.4. Thank you. And now, our people from task 6.1, AMS in human health, is following with the presentation.
Hello, everyone. So my name is Maria Núñez. I'm from Andalusia healthcare system, and she's my colleague, Blanca Bradley, at the Spanish Medicine Agency. So we are here also with Rocío Fernández, Antonio López, and so many colleagues, and Pepe online connected. And we are here basically, well, we are on behalf of 6.1, as José said, antimicrobial stewardship in humans. But we're here to say thank you, first of all, to all our amazing partners, collaborators, and all the work package that we all collaborating together as well as working. And I'm saying this because I have to confess that when we see the grant agreement every time, we are like, okay, JAMRAI is crazy. It's like so many things we need to do in such a short time. How are we going to manage? How are we going to do this? And it seems impossible. But after, if we could look back, and after we're going through months and months and we're going back, it's like it's become a reality. So someone said yesterday that if you want to have a nice recipe, you need to have good ingredients. And I think that's one of the main things that JAMRAI has done, especially, well, at least it's our impression in antimicrobial stewardship, is that the people here, the experts that the JAMRAI has been able to engage, they are brilliant minds, they are super motivated, and they want to work. So that's the title of our work in this program. It was like from paper to action. And I think we managed to do that. We want to show our actions, thanks to our colleagues and co-workers and everyone. So we'll show you some results. So what has happened from Bilbao to Vienna? Just a brief reminder is like in 6.1 we have like 2 lines of work. One is like we need to develop common frameworks on core elements, core competencies, like standardized, like working all together. And the second one, the other line that we'll see, is like bringing together those experts, those people, like more expert or with less expertise, but working on the field, to bring together best practice, share experiences, so we can do that together. So that's to foster this chain of experience and to foster implementation. So I hope not to press the black button. For the first line of work, the overview of current status of what AMS are. Well, we always say in all the meetings, we are not starting from scratches. There are a lot of things. So the first thing we had to do was like to try to map, to talk to already existing initiative, other societies, say what's going on already and where we're going to start from. So that's what we try to do. We have a lot of meetings, we collect a lot of information, basically from international surveys. We conducted 3 surveys and also 3 on-site workshops, and they were about the 3 settings: hospital, primary care, and long-term care facilities. So they gathered like hundreds of participants. The response rates were amazing, and you will see some of the results now. And for the second part, I'm going to end up here. It was like we need to start this exchange program. So how are we going to do that? We started laying the foundations for those programs. First, we map what other programs were on track. We will also contact with the other work package to see how we're going to do these synergies, this interaction, so we can improve and use our resources better. And we started to develop with different working groups, like the standard procedures, how we're going to start, how we're going to do it. And also to match this expert, we need a digital platform. So to see which are the functionalities or the items required, so we can make further actions later. And with no more, I don't want to speak more. Blanca will speak later and close the thing. But we want to show a video so all our participants and partners and collaborators want to give their opinion on what we have done this year. So.
Hello.
There it goes.
Hello, my name is Bojana Bejovic. I'm an ID physician in Ljubljana, Slovenia. Close to 1% of EU population lives in long-term care facilities, mostly long-term care facilities for elderly. Antibiotic use in long-term care is a couple of times higher than in the community, and many residents are colonized or infected by multi-drug-resistant bacteria. This is why a part of Work Package 6.1 was dedicated to antimicrobial stewardship in long-term care facilities. The activity started in the survey that aimed to identify the situation in Europe and the coverage of AMS activities in long-term care facilities by national action plans for antimicrobial resistance. The survey was followed by a workshop that was held in May 2025 in Ljubljana. The results revealed large variations in the governance of the facilities in Europe. National action plans in several countries mandate antimicrobial use and resistance surveillance as well as AMS programs, but in most cases they have not been implemented. Practical solutions were proposed in the workshop, including harmonized surveillance tools and standardized education. Participants of the workshop from ministries, academia, and healthcare providers, including general practitioners working in direct care of long-term care facilities residents, emphasized tailoring AMS programs to local context while maintaining common core competencies. Thank you very much.
Hello, my name is Anne Versporten. I'm based in Belgium, and I attended a workshop on ambulatory care titled Building a Unified Approach in Europe, held in Madrid in 2025, which provided valuable insights into antimicrobial stewardship in primary care across several countries. Importantly, I found also that the role of rapid diagnostic tests, together with accessible antimicrobial prescribing guidelines, are practical tools to improve antibiotic prescribing practices in the ambulatory care setting. And there were really points of discussion. Moreover, evaluating the appropriateness of antibiotic prescribing in primary care also depends on good metrics, well-defined metrics, and relevant determinants, which are also essential for shaping effective policy responses. Clearly, investing in antimicrobial stewardship in the ambulatory care to promote appropriate antibiotic prescribing will reduce antibiotic pressure and by consequence also its impact on hospitals. The roundtable discussion sessions brought together professionals directly involved in EMS, and it was an interesting time, I felt. Importantly, the sessions helped us to identify similarities and also differences between countries, and that organizational models vary, confirming the need for a flexible framework. So thank you for listening to me.
It's a long video, sorry.
Hello to all colleges. My name is Adonis Barakos and I'm working in Greek National Organization for Public Health. In Athens, experts from across Europe came together for a workshop supported by the JAMRAI 2 program with one main shared goal, strengthening antimicrobial stewardship in hospitals. Antimicrobial resistance remains one of Europe's most urgent health challenges. During this workshop, participants explored how hospitals can work within a harmonized framework that supports safer and more responsible antibiotic use. By sharing experiences and practical solutions, the workshop was the first step to shape a common European vision for hospital antimicrobial stewardship, moving from fragmented efforts to coordinated action and from knowledge to real impact for patients and health care systems. Thank you very much for your time.
Hi everyone, I'm Lucie Cato and I'm speaking on behalf of ESGAP, the European Society of Clinical Microbiology and Infectious Diseases Study Group for Antimicrobial Stewardship. ESGAP brings together experts around the world in order to advance the science and practice of antimicrobial stewardship, promote education, and support the implementation in diverse healthcare settings. In the context of EU-JAMRAI Work Package 6.1, ESGAP has been actively involved in shaping the work on antimicrobial stewardship in human health. We collaborated in designing 3 European surveys for hospitals, primary care and long-term care facilities and contributed to the 3 face-to-face workshops by chairing sessions, moderating roundtables and facilitating expert discussions. Looking ahead, we are excited to continue this collaboration and support the development of a European AMS framework, the peer-to-peer exchange programs and the emerging digital platform that will connect and empower AMS professionals across Europe. Together, we believe we can strengthen AMS, improve patient care and help make Europe a best practice region for antimicrobial use.
Hello. My name is Maria Ceroni. I am an assistant professor of infection prevention and control at the nursing department of the National and Kapodistrian University of Athens, and I collaborate with the Hellenic National Public Health Organization in the framework of the JAMRAI 2. Within a work package 6.1, I contributed to the development of 2 standard operating procedures under a common peer-to-peer framework for antimicrobial stewardship in human health, one for online mentorship and one for on-site observership programs. The mentorship procedure provides a structured but flexible approach to support healthcare professionals across hospitals, primary care and long-term care facilities, focusing on peer exchange, capacity building and implementable stewardship actions. The observership procedure complements this approach through short, targeted on-site placements in hospitals and primary care, enabling the transfer of tested practices to participants' own institutions. Together, these procedures provide an implementable model aligned with EU priorities on AMR, with potential for piloting, evaluation and scale-up within JAMRAI 2 and beyond. Thank you.
The last one here.
Hi, I'm Marta Gutierrez and I'd like to share why I am excited about the EU-JAMRAI platform about to come that will connect antimicrobial stewardship experts across Europe. This tool will make it easier for professionals from different countries to meet each other and share their knowledge, experiences and best practices in a more direct and dynamic manner. Instead of working in isolation, we will have a common space to exchange ideas, solve questions among peers. The real value lies on how quickly we will be able to identify what works and adapt it to our local context. It's a great opportunity to strengthen collaboration and accelerate progress in addressing antimicrobial resistance together as a one European community.
Well, thank you very much. As you've seen, we wanted to be creative here, so that's why we brought this video from different perspectives to show what we have done during this 2025. So now I will just finish this presentation by informing on what is to come on 2026, as we keep on enthusiastic for the work we have accomplished over these past 2 years. This 2026 will bring we will keep on working on the development of these 3 frameworks on core elements and competencies, not only for hospital, but for primary care and long-term care facilities on stewardship. We will also be rolling out and piloting the mentorships and observerships, putting into practice the operational procedures that has been mentioned by Maria and also by and on the video. And also we foresee to see the launch of the tender for this digital platform that we will be hosting all the peer-to-peer programs and will be connecting experts around Europe. Finally, I would like to take the opportunity to thank all partners, as Maria said, and all collaborators for their work, dedication and support. A special thanks, of course, for the colleagues that have been starring in this video. And of course, I won't forget Pepe for his always great work. And of course, this homemade video, he needs credits for this. So just to wrap up, drawing on all evidence that we have been gathering, also the insights from EU-JAMRAI 1, from other work packages and other EU projects experience, we think that everything will be contributing to strengthen the whole by adding value through synergies, interactions, and shared learnings. And so this is from our side. Thank you very much for your attention. And I believe we will have a short questions and answers session. So if my colleagues from 6.4 want to join. I'm not sure if I'm on the right place.
Is there any question?
Cannot see. Yeah.
Hi, this is Lukáš Macenaura from Czech Republic. Thank you for your presentations, and I would like to ask about the adaptability to different language variations, namely, the use of AI. That was very inspiring. So, shall we wait for the end of the pilot and then, try to get it to users in different countries? What's your take on this?
Yeah. I've used it in English and in Spanish, and it works well in both. That's what I can say. My experience now with LLMs, especially frontier LLMs, is that the language is less of a problem than it was previously. But I can't say that for every language. Spanish and English are quite, there's a lot of, the population base is higher and there is much more information there, everywhere there. But for sure, if you think if everyone in the JAMRAI think this is a concern, and it may be, we can try to validate that, at least for some languages. We can choose some languages and choose because validation, it also takes time. And we should do it strategically to think if validation how.
Thank you.
Because our idea is afterwards, this is pilot.
Time for the others to make their questions. Sorry, José, that we have very few.
Okay.
One question there.
Yeah, okay. Thank you for this nice questions. I'm involved in the veterinary who will be presenting now. But I was wondering, because this AI toolkit and also the digital platform, did you think of connecting us with that as well? Because that would be great.
Who is the question for? It's for
well,
me?
both. I think for the toolkit and also for the platform. I think it would be great if we, from the veterinary and environmental side, can benefit from that as well.
Yeah, we are developing and validating the tool mainly from the architecture and how it works with human health, because it's more information on how AMS are structured. So this is our first step. The second step is to find a sustainable way to incorporate this and choosing the LLM. And third is connecting their platform with our tool, because it's very much similarly oriented. It's team-based, it's individual-based from a team, institution, and so that will be our part. Once the tool has been technically proven and validated, in 2027 we will try to approach the vets. But we'll try to do it, but the context is so much different that it will be difficult. But if the architecture works, if we provide the right context, it can also be useful for vets.
Well, I think it's you.
Can I jump in? Yeah. Related to the platform, of course, we are trying to include the animal health and the environment, also training materials. It is a question of and IPC as well, of course, sorry. So we are trying to build it, but there is some challenges on the tender, and of course in the sustainability, who's gonna embrace the platform when it is a One Health real platform is a challenge that I also give to the audience, to the ones that can solve it.
I think One Health was the initial approach, but it's challenging. So, yeah. There's one more question there.
Hello, everyone. I just want to make a comment, just coming back what else mentioned. Actually, first of all, thank you so much for your presentations. Very exciting to see these. We just want to highlight that the companion animal field is pretty much what you see in the medical setting. Unfortunately, we might not have your resources. So, if you're working in a referral third opinion practice, yes, you'll have resources like you have in a human hospital. But, all the challenges that you mentioned here in relation to MS and IPC, behavior change, we are also facing. So that's why we were kind of thinking that, it would be very, very beneficial to work together. And, as you have been challenged in working on some of your, protocols for a little bit more time than us, I think that would be beneficial for us. And we will bring a different perspective, because infectious diseases are all around. Antimicrobial resistance is a problem. When we are veterinarians are much more than treating animals. We are responsible for public health. We have a really important role in that area. And, I think that our contribution is really, really important. And we have a huge responsibility as well in the impact of the environment. And of course, the farm veterinarians have different challenges, but, the principles of IPC and AMS are also applicable. I just wanted to clarify this because we've been working hard, and that many times we kind of think about livestock production, which is really, really important to produce safe food for people, but we also need to have safe animals and with good welfare. And all of these together will have an impact in the environment. So really, we really need to work all together because our end goal is to have a healthy planet, because only then we can have people that are healthy, animals that are healthy, and mainly keep our ecosystems working. Thank you.
Thank you very much for your comment. I just want to give just a brief comment. We fully, completely agree. We even for the workshop, we included, in our partners in discussion table, we invited people from environmental, from veterinary, to do this One Health approach, but like in reality. So we have discussion table, like we have these challenges and problems with governance, with implementation. So they could give feedback and to speak the same language, because at the end we all find this huge heterogeneity, also similarities. So we're starting from zero. So where we started, how can we organize and put it all together? I'm sorry, because she wanted to say.
Just 1 second to say that we don't have.
Can I say one thing only?
Okay.
Sorry, can I say one thing very brief? Just following on else there.
I'm sorry, but we really need to
give me 30 seconds. Only 30, I think it's important for this.
We are going to be on the info point, all AMS together, because we do actually work internally.
Yeah, I could have said it already. Else and myself have taken the certificate for the SMIC. And if you include us in we are the organizers of those parts. So if you include us in the emails, we will jump whenever we can. That's it.
Okay. But anyway, we will be on during lunch on the AMS point, so we can talk and discuss. Thank you. And sorry for taking the time. now, of course, is my colleagues from veterinarian side and also from the environment. We do work closely together from the first moment, so we are aware that we need to have one health approach and every sector is important here. So, Maria, this is your turn. Isaura.
Thank you, Blanca. Yeah, just wanted to reinforce what Blanca is saying. In AMS, we are sitting all together in the same building, so we work very closely. Unfortunately, the resources are what we have. Anyway, this is Isaura from Utrecht University. Sorry. And I'm Maria Vilar from the Spanish Agency on Medical Devices. And we are going to give you a brief overview of what we have been doing in this antimicrobial stewardship in animal health. So as you see earlier this morning, as you see earlier this morning in the video shown by our colleagues in IPC, we are working together, closely together to elaborate evidence-based guidelines, standards for AMS and IPC, while enable engagement of different stakeholders. So, very briefly, to remind you what was one of the outputs from JAMRAI 1, and it was to create and elaborate a white book on implementation and development of efficient and sustainable AMS programs. And that was because although the existing guidelines, tools, programs that already are in many countries in Europe, they differ greatly in terms of aim, animal species who are addressed to, in terms of who produced those guidelines, and also the type of document, if they are policy brief, research papers, and so on. So having those things in mind, we are preparing and drafting two different frameworks, one for companion animals and another for food production animals. And they are intended to be a practical tool for all member states to develop and implement sustainable and efficient programs at national and animal sector level. The idea is to have those frameworks as an overarching perspective to facilitate their adaptation to the particularities of each member state and also to the animal sector. And for doing that, we have a lot of partners, highly motivated and committed with this work, and they organize, or we organize ourselves in 4 different working groups, one for cattle, another swine, poultry, and companion animals. And they are working together, having regular meetings online. Yesterday, we have our last meeting face-to-face with really great discussions. So we are drafting those guidelines. And those guidelines are, sorry, I wanted to say a lot of thanks to all of you for your great work, because otherwise we won't be able to do this within JAMRAI. So to create these frameworks, we are using, or you are using, your own expertise and experience on the field. We are using information collected from the workshop we held last year in Bilbao, as shown in the video earlier this morning, but also some information from the literature review conducted in collaboration with Federation of Veterinarians in Europe, that they review the all available programs, guidelines, tools on AMS worldwide on animal sectors. Plus a survey that was conducted also last year to all different member states to collect non-published information. And with that, we are preparing 2 documents nowadays, and they have 2 different sections. One common, where there is the definition, different definitions, where it has a description of the objectives of these frameworks, the methodology, and the approach on how to use them. And they have a more specific session, different for each animal sector, where we define the different core elements, the different core competencies, and some indicators to assess the progress of implementation. So regarding the core elements, each working group followed their own approach to select which one should be included in the framework. But we use overall as a reference the WHO toolkit, and we were able to identify 6 overarching core elements like leadership, accountability, education and training, monitoring, surveillance, reporting and feedback, and some technical pillars for AMS. Those technical pillars are strategic or actions or activities with the objective to optimize the use of antimicrobials to improve treatment outcomes, and also to reduce the antimicrobial resistance, but also in the selection of the appropriate antimicrobial and alternative therapies if they are available by conducting diagnostic tests. And I pass the micro.
Yes, thank you. These guidelines for AMS, they are not only containing the core elements, but they will also contain the core competencies, which was already mentioned in all other work packages as well, the people who are going to do it, and also we are also thinking and including the skills the people need. And we are also developing indicators, or in other words, the levels of implementation. So we started with 3 levels of implementation: basic, intermediate, and advanced for all these core elements. But as Maria mentioned, we had yesterday also discussions again, and then we discussed maybe 2 is enough. So this is still in progress at this moment. So this frameworks, guidelines, they are finished this spring, this year. And then we have the first draft of these guidelines. And if you can follow me with the blue line, you see, well, we have a first draft, but of course the working groups, as we said, we have split them in 4 different working groups, but we, of course, all the guidelines need to be shared and reviewed by the other working groups, so all of the partners. That's the first loop. Then we are going to the second loop to review them much better with our colleagues of the human side, behavioral experts, and at least the last loop also environmental. So we have good reviewed guidelines. And it comes as no surprise that, as you could see in the core elements, a lot of, those core elements include some overlap with other work packages: surveillance, IPC, and access. And of course, we prevent overlap. So we discuss where is the overlap, and maybe some parts, like biosecurity was just mentioned yesterday, of course, that needs to be in IPC. So we are in close contact. And with that, we have reviewed guidelines. We expect to finish them in fall this year. And then we want to implement them further. So we have another working group, a really great working group, and they are going to organize peer-to-peer trainings in 4 regions of Europe. We will start this fall with that, and next to that we will identify mentor and mentees, and we do peer-to-peer actions with basically the goal to also to implement and further improve these guidelines, basically to test them out in the field and to see how that is going to be. And of course we take all these experiences together to include in our expert network. So to summarize this, we also have a roadmap. You already saw the start of this roadmap in the presentation of IPC. I see some people laughing. It fits perfectly with the car from yesterday and the plane, everything. We started with evidence, the surveys, the literature reviews. We have the workshop where you see the movie from IPC and AMS on this morning. We want to have engagement, so we made reports, publications. We have the focus groups from IPC. We need alliance. We need the expert network for AMS and IPC. And finally, this year, capacity building. We also start a series of webinars, Voices from the Field, based on experience from last year. We wanted to have more case studies, really practical studies from the field to be told to all the partners. And of course, we are going to do the peer-to-peer activities, all to have the results, the frameworks for AMS and IPC at the end of the EU-JAMRAI 2 period. And to give you a glimpse of that, this morning we started with the video of the workshop in Bilbao. Now we are going to show you a video how we are going to take all these steps together for the upcoming time, the upcoming year. Well, thank you. This applause is basically for the communication team. Thank you for making two really great videos for us. We are going to pass the word to my colleague of environmental, but we still have a Q&A session after this. So here is Anne.
Thank you. Okay, good morning. I'm a co-leader for antimicrobial stewardship in the environment, so I'm pleased to present the progress of our work this last year. I will begin with the roadmap of our task to provide you with some context. Then I will focus on presenting the two main results we achieved in 2025. And to finish, I will outline our next steps for this new year that begins. Then, as you know, we need to implement a pilot training program on environmental AMS. And in 2024, our work focused on laying the foundations. So we identified our priority target audiences and built a strong network of collaborators. We also identified gaps in knowledge practices and attitudes related to the issue, and reviewed existing training materials on the topic. So building on that work, 2025 was dedicated to developing operational tools. We created a digital tool to support the selection of training methodologies and formally designed our pilot training program. So over these 2 years, we also had the opportunity to meet in person. We had 2 workshops that were very crucial to moving the work forward, and especially the last one was very important because we gathered all the people working in environmental health within this joint action, and we also had all the colleagues from human, veterinary, and communication teams involved. So it was very good to align our strategies. And then looking ahead, we can say that 2026 will be the year we deliver concrete materials and activities. So we are now transitioning between the design and implementation stages. Good. Focusing on the first result from 2025, according to the grant agreement, we had the mandate on using innovative training methodologies that could generate deep, sustainable, and transformative capacities. So we explored theories of adult education and a variety of innovative training methods. And then we compiled all the information found into a preliminary report. And in this document, we categorized 25 different methods based on factors like the learning modality, costs, or, for example, time considerations, and also created a matrix of recommended methods according to the different professionals involved in AMR that included many different profiles from healthcare workers to food producers or even wastewater managers. Now, so next, we proceeded with a consultation exercise to validate this matrix. And then we conducted 2 focus groups where representatives from the key target audiences participated in guided discussions. And I want to again highlight that these focus groups involved people from all the different fields. So even if this came out from our task, which is focused on environmental health, it can be very, very useful for anyone wanting to develop trainings on AMR, regardless of if they are focused on human, veterinary, or environmental approaches. So yeah, this is the result. You can find it on the website. And well, finally, after these focus groups, we got a validated report, but it was almost 200 pages, so it wasn't exactly the easiest thing to use. And therefore, we decided to make it more practical and user-friendly, and that's how the idea for the digitalization came about and led us to reorganize all the content into an interactive online tool. And this is how it looks like. And I also want to acknowledge the communication team, because they've been crucial for the contracting and also for the digitalization of these contents. And please, if we can see the video, so we can learn more about this tool.
First, access the EU-JAMRAI 2 website through your browser. Next, go to the Training and Education section and scroll down to the AMR in the Environment section. Once there, access the digital tool by clicking on the blue box. At the top, you will find a summary with a description of the tool. Further down, you can start using it to select the innovative training methodology that best fits your objectives and available resources. You can learn more about specific methodologies by typing their name directly into the quick keyword search bar. If not, and you prefer the tool to suggest methodologies based on certain criteria, expand the advanced search using the filter system. You'll be able to filter based on different criteria, such as the target audience, learning modality, training environment, etc. Before selecting an option, you can check its definition by clicking the question mark icon to the right of it. Once you finish selecting your filters, the tool will return the recommended methodologies based on those criteria. Click on the name of a methodology to access its step-by-step implementation guide. You will find a table of contents on the right to help you navigate the content. The step-by-step guide includes a clear planning outline for the selected activity, a description of the relevant participant roles, recommended evaluation methods, and a prototype that serves as an inspirational example of this type of activity in the context of antimicrobial stewardship. It also includes a summary of the scientific literature that supports the content. If you wish, you can easily download the guide by clicking the button in the top right corner to save it as a PDF on your computer. On behalf of EU-JAMRAI 2, we hope this tool inspires and supports you in delivering meaningful training interventions that advance antimicrobial stewardship and contribute to long-lasting impact within this joint action and beyond.
Okay, so this is a tool, this is available online, and we will be, presenting it during the corner meetings. It's called AMS Info Point, so if you want to learn more and navigate together, you can come approach us. Then, so once the tool was launched, we started using it internally to choose the methodologies for our pilot trainings and further define our program of activities. So we set the filter system to include all learning modalities and a high level of interaction while keeping time and cost moderate or low. Then we discussed different options suggested by the tool and went for the community of practice because we felt that it was the most complete approach as it can combine a variety of methodologies within a single setup. And now another video. Let us tell you a bit more about our community of practice and the program of planned activities that we have.
A community of practice is defined as a group of people who share a concern, a set of problems, or a passion about a topic, and who deepen their knowledge and expertise by interacting on an ongoing basis. What is the goal of this community of practice?
Our community of practice, or COP, focuses on the environmental dimension of antimicrobial resistance within the European Union. Aligned with the One Health approach, our goal is to 1. Bring together relevant stakeholders across sectors, 2. Raise awareness and build knowledge on the environmental dimension of AMR, and 3. Promote the integration of environmental strategies into AMR policies and practices across multiple settings.
How is this community of practice actually going to be built?
So we are going to use a hybrid approach with both online and in-person activities, and we plan to do this in 2 steps to move from learning to practice. First, we will create an online space where participants from the different sectors can find learning resources to understand the environmental dimension of AMR, and once everyone has a shared understanding of the issue, we will meet in person for hands-on sessions that will be very practical, giving participants a chance to work together and learn how to apply these best practices in their own work.
Who will be part of this community of practice?
Collaboration and knowledge sharing are at the heart of the COP, bringing together a diverse range of stakeholders across the One Health approach. We have identified the key sectors and professionals working on environmental aspects of AMR, and they will take part in the pilot project through their representatives and institutions. Many of these participants have already been actively engaged at the national level.
We aim to strengthen AMR governance by integrating environmental strategies into Europe's national AMR action plans.
We are committed to expand stewardship in healthcare to include environmental perspective and sustainable management practices.
We will promote awareness of the AMR's environmental dimensions in the food production and the animal health sectors, and will support the implementation of best practices that can help reduce AMR spread.
We aim to support the upcoming implementation of the European Union recast Urban Wastewater Treatment Directive by building capacities to curb the dissemination of antimicrobial resistance via wastewater.
Please visit our website to stay informed of the COP's ongoing advances.
Thank you very much to the contributors as well, and to Victor for helping me with the editing. And finally, what's next? Well, we are currently working on creating content to feed the online platform of this COP, and we will present these contents at the 3rd year workshop in June, and I am pleased to announce that it will take place in Athens and be hosted by the Hellenic National Public Health Organization. And after that, we aim to design and implement in-person activities starting in the 2nd half of the year. So that's all. And now I call back Maria and Isabel on stage.
So I think we have some time for... There is some time for questions from the audience, so don't be shy. We cannot see you, so... If not, we will ask you directly, so it's better you ask first.
We also have a mentee.
Yeah, that's why I'm...
With them.
Yes, I think that's a good idea. If there are no questions in the, then yeah, can we put the Mentimeter on?
Anyway, there will be follow-up questions to them, so...
Yes.
We cannot see you anyway.
We cannot...
Maybe you can just speak.
Yes, this one. So everyone can log in with their phone. Hopefully.
Okay, so you want to start? Because first questions are on animal health.
So maybe we can... I don't know if I have to press the black button for this or... No? No. Our first question is regarding the core elements we have selected. We have not mentioned all of them during the presentation, but you can run which ones do you think are more relevant in companion animals. So monitoring and surveillance.
Yes.
So we see here the importance of collecting data on antimicrobial resistance, but also in antimicrobial use. So.
Yes, as the work package about surveillance is about resistance. I cannot see where Lucy is, but she is somewhere here. This is more about the surveillance, like the use of antimicrobials for companion animals and how important it is for AMS. And most of you agree, and also education and training is high up. But the technical AMS actions, they are staying behind.
Interesting. Yes. Okay, let's go to
the next
food production
question.
animals.
Oh.
Same question, but in food production animals.
And to see if you think a difference is needed for food-producing animals, which is interesting, because of course food-producing animals, they are in a completely different context, and a lot of you are doing human medicine, so we are curious.
Here we can move one.
So, yeah, can we go to the next? Yeah.
Interesting, the third one.
Yeah.
Well, till now, there's more focus on the regulations and policy. Is there someone who wants to comment on that? Why they think that's the most important for livestock?
And also, if you miss any other core element, either in companion animals or in food production animals, that we should consider and be included in the guidelines, we would like to hear from you. Nothing. We are perfect. Okay, so let's move to the next one.
Yes, I think that's...
So people, that question is about who are the professionals more needed in these programs. And you can also vote for the ranking.
Is there someone that is saying, like, I miss an actor here in this list? We would love to hear that.
Pharmaceutical industry.
Mm-hmm. Yeah, the industry, yeah.
Yeah,
okay.
well, industry is there,
Yes. Meat consumers, someone is saying?
Why
Like
only
the
meat
public?
consumers?
Sorry?
Come to discuss with us in the info part.
Yeah. I think it's good to go to the next question because.
Okay. So we are now moving from the animal domain into the environmental one. What should be the ultimate goal of environmental AMS strategies? And this is a discussion that we are having internally. As it is an emerging topic, we are wondering maybe if the ultimate goal is protecting human health or the ecosystems themselves, or maybe animal health as well. Plant health protection is also raising, and well, we have this concern with fungicides. Good, so this is quite similar to the responses that we are getting internally, not now, because there was a change as I am talking. Okay, so you think it's ecosystem health protection? Yeah. I know, it's just like a prioritization exercise, but it's not leaving things out. Well, we will take this into account because it's not exactly the result that we have internally. So maybe we can next into the next one. It's okay. Not yet. Now. So how can antimicrobial stewardship frameworks be expanded to include environmental approaches? This is another discussion that we have, and this has been mentioned already in the IPC session as well, that we have a term that cannot fit into environmental approaches, or maybe it should be adapted. So do you think that we should be integrating environmental considerations into human and animal AMS strategies? For example, like you did, that you are including this section about manure treatment in your AMS guidelines for food-producing animals? Or do you think that we should develop context-specific core elements for environmental AMS? Or both? If you want to comment on this. We don't need to choose one or another. We could go for both.
We will happy to follow up all these questions in the info corner. So if we don't have time now.
Actually, we have 20 seconds to go. Okay, so do you think mostly that we should be integrating environmental considerations, which I think it's very feasible and quite easy to do? Or the easiest strategy, at least, I would say, as long as sectors are open for collaboration, of course.
Well, we are.
I know you are. Yes, we have another question, but I think we can leave it here. Yes, and continue the discussion in the meeting point.
Yeah, thank you.
Sorry. I would like to introduce and give the floor to Marta, who will do the closing remarks of this session. Thank you.
Thank you. Thank you, ladies. Well, for the sake of time, I'm going to read, and hungry. We are hungry, so I will be brief. Good morning, everyone, those here and online. As we wrap up this discussion on the work done in AMS working package, it is time to reflect some remarks. We are in a pivotal moment. These last 2 years, our task leaders, together with the several partners, shaped the plan, built consensus in procedures, and created foundations for the future tools that will guide our work ahead. Now we move from planning to implementation. Our working groups are already active, working on the frameworks, guidelines, and training materials. Networks on AMS experts will be fed in the coming months, and tools and programs need to be piloted. So for that, we need the collaboration of all of our partners and stakeholders. So I do not want to end this AMS update without saying thank you for the work done to the whole team, and thank you for the commitment to accept the challenge ahead. Our technical officers will be in the info corner during lunch today and tomorrow during the coffee break, so please do not hesitate and visiting us for further information. Oftentimes it's not enough to go in deep in some subjects, so we will be happy to chat with all of you, and thank you very much.
Thank you very much. Thank you very much. So thank you for this insightful morning. So now it's time for lunch, when you can also continue to discuss behind with the info corners. But before leaving the room, please, I would like to call you for a photo. And the quicker we get this done, the sooner you can eat. So please follow the instruction by Richard to do it as quickly as possible, because we are already 10 minutes late.
And we will start back. We'll start back.
Yes, and we start back, please, at 2:05 to be sure to start on time. Thank you.
Okay, thank you very much, Marie-Cécile. May I have your attention for instructions right now to be effective? So, to be included in the photo format, in the photo frame, I ask the people seated in the side to move as much as possible in the centered seats. May I have the microphone? There are empty.
Please, can we come back? Can you come back and sit? And I promise you we'll have another break to discuss after. At the end, we will end sooner than yesterday, so you will have plenty of time to discuss in the late afternoon. So please, our last stop of the day is about communication and awareness raising. Communication connects everything and everyone. Explaining resistance in ways that engage family, farmers, pet owners, doctors, nurses, veterinarians, citizens and policymakers. Awareness turns science into action. And because AMR is not just a microbiological challenge, it is social, cultural, and deeply human. We are raising awareness and communicate from evidence with an engaging perspective through our words, the context, the backgrounds, and the ideas. To end our EU-JAMRAI 2 journey, let's welcome the colleagues working on communication and awareness raising. And for that team, I don't have to explain where to stand, how to speak, because this is their job every day. So, thank you very much. And so I call first on stage Laura Alonso and Richard Vaux. Thank you.
Okay, thank you, Marie-Cécile. So, thank you so much for being here after lunch and being on time. Now it's time to talk about awareness raising. In EU-JAMRAI, you know that we take communication very seriously as a core part of our effort to contain AMR. We often think about science communication as just a way to explain complex information, but it is much more than that. Science communication is an opportunity to engage the public. It's about connecting evidence with real people and real concerns, while trying to promote positive behavior.
So in the next hour, the communication team will briefly share the following: some results of our dissemination efforts, and also the studies, campaigns, and activities developed during the last year. And after that, we will have time for questions, hopefully. And finally, we will share the next steps.
So let's start with dissemination. And we know that you might be a little bit sleepy now after lunch, so we have decided to tell you a story. So let's imagine that our EU-JAMRAI 2 is an Erasmus student, traveler, curious, eager to know their European countries and neighbors, and of course a very fast learner. In this story, events are the social life of our Erasmus student. This is where she meets people, exchanges ideas, and realizes that her concerns, her challenges are shared across countries, but just in different languages and different contexts. Conferences, workshops, meetings. This is where EU-JAMRAI 2 becomes a conversation, like here in the annual meeting. And like every good Erasmus student, if they're good and they have good grades, of course, there's a time to stop partying and speak about numbers, right, Richard?
Yes, indeed. Of course, through events, EU-JAMRAI has been actively present across Europe.
Next slide.
Oh, sorry. In total, the project has participated in 58 events covering 18 countries. And these events allowed us to reach diverse professional audiences, strengthen networks, and increase the visibility of the project in different contexts.
And now let's speak about our website. In our Erasmus student story, it will be her portfolio. This is where she brings together the work that he has developed and also what she's capable of. The website is where the project is presented in a clear and structured way. It brings together resources, campaigns, news, updates, and results.
So some figures about the website, because it has shown steady and growing engagement. And indeed, during the last year, it recorded more than 82,000 page views and over 43 visits and close to 38,000 visitors, which is an achievement. These figures reflect the sustained interest in the project and in its activities.
And of course, social media. If we are young and if we are an Erasmus student, we have social media. This is where our student shares everyday life and stays connected with old and new friends. Social media is where EU-JAMRAI becomes more informal and more human. It's about listening to and keeping the conversation alive. And sometimes it is also the place where EU-JAMRAI partners pretend to behave like young people.
So once again, in 2025, EU-JAMRAI published a total of almost 200 posts across social media channels, and this generated more than 11 million impressions and an increase of over 428% compared to the previous period. And the project reached more than 7,000 followers across platforms and recorded over 38 interactions, which shows the strong and growing engagement.
I left you the hard part with the numbers, Richard. Sorry. Now the newsletter. In this story, this is where our student writes home from time to time. You know, they're busy partying, to explain how things are going. The newsletter allows us to step back a little bit and summarize the most important updates. It is shared with a close and interested community that follows us very closely.
So, the EU-JAMRAI has sent a total of 7 newsletters since the beginning, reaching close to 1,900 subscribers. And the average opening rate is over 32%, which is above the average for this type of institutional newsletter, and show consistent interest from our audience.
And then we have our Tuesdays Connect. This is where our students attend in-depth online classes, a regular space to stop, focus, and learn together with others.
So our Tuesday Connect is a monthly webinar series designed to bring together experts, policymakers and stakeholders so as to discuss key topics related to antimicrobial resistance and share updates on the joint action. And so far, a total of 10 Tuesday Connect sessions have been organized, and the sessions have generated strong participation with more than 1,200 live connections. The topics covered reflect the diversity and depth of the work carried out within the EU-JAMRAI, from access to antibiotics and stewardships to surveillance, and of course the One Health approaches. And finally, we come to the Lancet, because for our Erasmus student, this is a very special moment. All her hard work is reflected in her first scientific publication. So EU-JAMRAI leaders have recently published a paper, Strengthening Antimicrobial Resistant Governance in Europe, a coordinated One Health approach. This in the Lancet Regional Health Europe, with a message that could not be more timely. The paper highlights that stronger accountability, political commitment, sustained funding and coordinated leadership are essential to turn strategies into action and protect citizens' health. It also underlines that strengthening AMR governance through a unified European approach is crucial to achieving lasting progress against AMR.
We have also submitted the illustration. Oh, sorry, one step back, please. The illustration you can see on the screen to the cover competition. The image takes the AMR symbol as the central element, shown as a work in progress, under construction. It conveys collective effort, process, and shared responsibility. Conceptually, the idea is that the symbol does not exist by isolation, but it is built together. A direct metaphor of the One Health approach, right? Where every contribution and every collaboration matters. We hope the illustration will be selected and will continue to inspire the scientific community. And I think that now it's time that we give a break to our Erasmus student. Thank you very much for your attention. Okay, and now we move to the block communication results, studies, campaigns, and actions. And it is my pleasure to call to the stage to our colleague Jonathan Gomez Raja from Fundesalud, who will present the AMR campaigns and messages study.
Thank you, Laura. Well, it's for me a pleasure to be here. I'm coming from the Salud Foundation, it's part of the government of Extremadura in Spain. And we have conducted a study to evaluate the state of the campaigns, messages, or all the material we are using right now in Europe regarding AMR. So for that, we identify what awareness raising messages and materials are present now in Europe, all related to healthcare associated infections and hand washing, hand hygiene in Europe. On the 30 European countries we are part of the project in the last 15 years, more or less, and all available in the national languages and also in English. What for? To understand the communication approaches, channels, audiences, objectives, what we are doing right now in order to improve, to raise the awareness regarding this matter. In the end, to identify gaps in terms of accessibility, equity, diversity, and communication effectiveness. The type of material documents we have reviewed is, as you see in the presentation, all the institutional awareness material, leaflets, posters, infographics, videos, websites, and so on, and also the reports from your national plans. This is a template, so we used. As you can see, it was a really huge work in order to collect all the information regarding basic information, target audiences, funding, strategy, evaluation, all these KPIs we were collecting in the 300 materials, 300 campaigns and material we identified so far right now. Here you can have some preliminary results based on these 300. Distribution by campaign, so mostly all the material, 80% is operates at national level, so reflecting the local engagement we have. Websites are the most frequent, and then social media. Although traditional media is still present in this. We have the format regarding digital and hybrid media, and also we have a gradual diversification of communication practices and some communication regarding this co-design and participatory approaches are emerging. The target audience. Mostly public outreach with professional and institutional engagement. A general public and healthcare professional are the first one in the list, but fortunately we see a progressive integration of the One Health approach and the One Health concept into the awareness raising practices in Europe. Key findings you have here. So basically everything is based on the international campaigns where the European Antibiotics Awareness Day by this ECDC or the Antimicrobial Awareness Week by the WHO, but everything rely on voluntary basis in the different countries to implement and to adapt these international campaigns into the different local environments. So we have some gaps regarding equity. Some vulnerable population is still underrepresented. And we need more tools for evaluation. So many campaigns and material are implemented but not evaluated. So we lack evidence on behavioral outcomes. And also, we need more innovative and participatory approaches. These are kind of recommendations we have so far based on this study. We need to promote sustained and evidence-based communication strategy. For sure, we need more evaluation about what we are doing to see if it is working or not. We, for sure, have to work on equity and accessibility, to collaborate and exchange, acknowledge regarding member states, and also to integrate the co-design, I said before, co-creation approaches involving patients, professionals, and communities. And this one, this study is a really, really nice study to find the best practices that we can implement in other countries. Everything is now, I mean, it's not available yet. It will be available on Monday or next week in a website where you can find all this database, when you can play it, when you can find, you can filter per country, per target audience, per material, etc., etc. And now is a time for you to go to there. You will receive some email from us on all the countries to go there, validate what we found so far, and also integrate your materials and campaigns that are not available because probably we didn't find it in this first study. So the idea is now is your turn to contribute and to share all this information. Thank you very much.
Thank you, Jonathan. Now let's call to the stage to our wonderful Anna and Victor communication colleagues. So creative and so great team to work with. Come.
Thank you, Laura. It's a pleasure to be part of this communication team. So, hi, let's now turn to the crown jewel of the communication work of 2025, which is the Sketching Antimicrobial Resistance campaign. This unique initiative brought together 30 illustrators from 30 countries with a shared goal to make antimicrobial resistance visible, understandable, and emotionally engaging. As many of you already know, the campaign unfolds across 3 complementary pillars: a strong social media presence supported by a dedicated website, an illustrated, beautiful album, and public exhibitions hosted in 5 countries. Video, please. I love this video.
Well, as you may already know, we are proud to say that yesterday, coinciding with this annual meeting, EU-JAMRAI inaugurated the first Sketching AMR exhibition. It is located at the University of Vienna. It's composed with the 32 panels, with all the illustrations printed in large format, together with an introduction, a conclusion to offer some context to the initiative. And the contents that complement the illustrations are both in German and English. However, an audio guide is also available, and you can play it on your mobile phone with narration in English, German, Italian, Dutch, French, Polish, and Spanish. The aim is to make this content more accessible and immersive. And in February, we will open the Sketching AMR exhibition in Warsaw, in March in Brussels, in April in Rome, in May in Madrid, and besides, some partners have shown interest in organizing the exhibition in their countries. So if this were your case, please don't hesitate to contact us and we can talk.
The illustrated book is an invitation to look closer, to discover the beauty of a balanced microbial world, and to recognize the power we hold to preserve it. Each illustration and each message contributes is a fragment of a shared story, a story that belongs to all of us. Because caring for our antibiotics ultimately means caring for life itself. 50,000 copies of the book have been produced and will be distributed across all 30 countries participating in EU-JAMRAI too. With the support, we want to thank to our communication network and our communication partner. And we are especially pleased to have brought copies here that you can take home and you can experience the book firsthand.
The illustrators selected to participate in this campaign, the social media campaign, has reached more than 12 million people across Europe and has achieved 38,000 interactions, including likes, shares, comments, etc. One illustration per day was published during November and December, starting in the framework of the European Antibiotic Awareness Day and the World Antimicrobial Awareness Week. And we shared them on our social media channels, Facebook, X, LinkedIn. But Instagram was the main channel for this campaign because it gathered the highest number of followers of the artist profile, and we could make collaborative publications easily. Regarding the qualitative analysis, the general feedback we have received was quite positive. We have also followed and listened to all the comments, and we were very happy to read things, for example, like this. We will translate. This says, "Thank you too much. This is extremely important during this week when hospitals and ICUs are full capacity." People trust our campaign and they shared their own personal stories. For example, this other one that says, "I love it, and yes, something as simple as washing your hands can really save lives. When my children were little, I was able to go to their class and talk to them about microorganisms. At the end of the talk, I had them wash their hands and put them on a plate. Just by leaving them at room temperature, the microorganisms grew, and even with freshly washed hands." So we were very happy to receive that kind of feedback. The campaign also presented a multilingual component. For example, on Instagram, each illustrator shared their artwork with the comment both in English and their native language. And we also created a specific web page for Sketching AMR, gathering all the illustrations and messages in 24 languages. And that page has had already 10,000 visits so far. And in the landing page, the illustrated album is also available to download in PDF format.
And all of this was built on a solid foundation. Scientific rigor and the genuine commitment from the illustrators. Before they put pencil to paper, we invited them to a webinar where antimicrobial resistance was explained in depth. Many later shared that the session was truly eye-opening, as several of them initially held misconceptions or had only very limited understanding of the topic. A strong foundation does not guarantee success, but it makes meaningful, responsible communication.
Well, the final result is very beautiful and we are very proud, but we also have to say that the process has not been a piece of cake. It has been a collaborative effort with different dimensions and many actors actively involved. And here you can see just an example of the dozens of documents we had to work on only for the translations into 24 languages. And we would like to take this opportunity to thank the AMR Communicators Network and our partners involved in Work Package 10, without whom sketching AMR would not be possible.
One of the most significant milestones for communication in 2025 was the European AMR Communicators Network workshop that we held in September in Brussels. The workshop was co-organized by FPS, Health, Food Chain Safety and Environment, and the Spanish Agency of Medicines and Medical Devices, with the support of the European Commission. This network was created with a clear purpose: to co-design and co-implement awareness-raising actions on antimicrobial resistance across all countries participating in the joint actions. Today, the AMR Communicators Network brings together 42 experts from the 30 countries of the EU-JAMRAI 2, forming a truly collaborative European community of practice. And beyond learning from each another, the network is built on a simple philosophy. We grow stronger when we also learn from voices outside our immediate field. That is why we were honored to welcome Dr. Eva Krokow from the University of Leicester, who joined us in Brussels to present her research on antimicrobial resistant metaphors, a study in which the EU-JAMRAI 2 communication team has actively participated. One of the key conclusions was stricken. While war and combat metaphors are often easily recognized and understood by the general public, most participants rejected belligerent language. They describe it as aggressive, overused, and ultimately misleading because it oversimplifies the complex nature of bacteria by portraying them solely as hostile enemies. This insight reinforces a core principle of our communication work. The words we choose matter, not only for clarity, but for trust, understanding, and long-term engagement.
During this workshop, we also reviewed and co-created many of the key messages for the Sketching AMR campaign to ensure they were appropriate and understandable in various European contexts. Besides this, our colleague shared the progress from the communication and education studies taking place in the framework of Work Package 10, like Jonathan has done a minute ago. And we brainstormed innovative actions that we are planning to keep on engaging the public with AMR. And we also exchange experiences and practices from different partners across Europe. So in conclusion, they were 2 inspiring days of collaboration, exchange, and creativity.
Working side by side with a stakeholder is essential to build shared understanding, foster trust, and co-create solutions that deliver real and lasting impact. In 2025, EU-JAMRAI 2 strengthened this approach through close collaboration with the World Organization for Animal Health and the World Small Animal Veterinary Association. Together, we developed targeted communication materials for pet owners designed to help them understand why antimicrobial resistance matters, what they can do to contain it, and how responsible use of antibiotics protects both their pets and themselves. These materials were produced in English, Spanish, and Portuguese, reflecting their primary audience, veterinarians attending the WASAVA World Congress 2025 held in Rio, Brazil. What began as a focused collaboration quickly proved its value. As a result, we plan to work together again to develop new materials for the WASAVA World Congress 2026, who is going to happen in October in Warsaw, in Poland. Alongside these materials, AMR pins were distributed both at the WASAVA Congress in Rio and at the WOA General Session in Paris, helping to spark conversations and increase visibility around AMR in key professionals setting. In parallel, we also co-created a second set of materials with WOA, focused on raising awareness of the impact of antimicrobial resistance along the food supply chain and highlighting the essence role of veterinary services in safeguarding animal and public health. Video, please.
But AMR doesn't only threaten human health. It also threatens our food supply chain. When livestock suffer from drug-resistant infections, production drops, food prices can rise, and shortages can become more frequent. By 2050, AMR could cause losses equivalent to the food needs of 2 billion people every year. That's approximately 1 in 5 of the world's projected population. Yet, there's hope. Through universal access to safe water and sanitation, stronger healthcare, and improved vaccination, we could save 110 million lives. And cutting antimicrobial use in animals by 30% could boost the global economy by $120 billion in just 5 years. So, what can veterinary services do?
This is only 20-30 seconds, but you can find the video on our website. And with this video, we took one step further, launching the One Health World animated video series, a new communication space where animal, human, and environment health come together through accessible storytelling.
Could easily infect our pets, severely compromising their health.
Well, since we had a really cool animated video, why not think about a series covering various aspects of antimicrobial resistance? And so it was born One Health World animated video series. We think these videos can be a useful resource for raising awareness on social media, but also an interesting material to support talks, presentation, educational activities, or any other raising awareness actions or events. At the moment, we have developed one about the impact of AMR in the food supply chain, which we have already seen. Another one targeted to pet owners and veterinarians, and the most recent one regarding the importance of hand washing for infection prevention. And let us show some highlights to you. Video, please.
Bugs resistant to antibiotics could easily infect our pets, severely compromising their health. And they can be transmitted between pets and their owners, in both directions. But we can prevent this from happening. Healthy pets don't need antibiotics. Taking your pets for routine health checkups is a critical step in preventing infections before they start.
Thank you. And we can see also the other one about infection prevention. The other video, please.
Today we know hand washing prevents infections. 20 seconds, soap, friction, such a simple act. And yet, one that can decide between health and disease. But 200 years ago, that idea sounded crazy. Hospitals were filthy. No adequate ventilation, no gloves, no soap. Women giving birth often died from infections caught inside those very hospitals. Then came Ignaz Semmelweis, a doctor in Vienna.
I don't know if comment on the woman or about Semmelweis, which was working in Vienna. Okay, so you have seen in the videos, sometimes talking about science is telling stories. And when those stories are shared in front of live audience, something special happened. We have the opportunity to evoke emotions, to listen to questions, and to create a genuine dialogue with the public. Communication becomes a two-way exchange. Throughout the projects, EU-JAMRAI too has taken part in a wide range of initiatives with a single goal: to bring science closer to people's everyday life. We have talked about antimicrobial resistance at the European Researchers' Night, in nursing homes, in schools, and on a stage in front of more than 2,000 people, among many other settings. And we truly value this way of raising awareness, because the science is shared openly, accessibly, and face-to-face, and it becomes more human, more memorable, and more impactful.
And well, you all know our symbol. It was created during the first edition of EU-JAMRAI, but it is during this second edition that is really spreading and becoming known. We have distributed more than 12,500 pins, which have traveled to congresses and events, even beyond the borders of Europe. It has also been featured on the cover of the Swedish government's new antimicrobial resistance strategy, or recognized in the Third National Action Plan of Ireland. And we have used the revision of the EU pharmaceutical legislation as an opportunity to promote the inclusion of the AMR symbol in antimicrobials. Over the past month, this initiative has gone through several steps: the preparation and dissemination of a position paper, its inclusion in Spain's official comments on the legislative revision, outreach through the EU-JAMRAI 2 liaison officers to national health attaches, and close coordination between the COM team, our estimated Antonio from AIMS, and the health attaches to support the proposals. Initially, we advocated for inclusion of the AMR symbol on the outer packaging. However, following opposition from 2 member states, we focused on the most realistic approach at this stage. And in the final trilogue agreement reached in December, 2 key points were secured: the inclusion of the AMR symbol in the package leaflet, and the inclusion of an awareness card of the proper handling on the proper handling and disposal of antimicrobials when the leaflet is digital only. So we now hope to see this implemented in practice, as it could become a powerful tool to raise awareness at the very moment when patients are making decisions about using antimicrobials. We received a proposal to use the AMR symbol in the promotional campaign for a BBC documentary on antimicrobial resistance. The name of the film is Love Our Antibiotics, and it is scheduled to premiere in the summer of 2026. And another wonderful proposal came from the Nobel Prize Museum, which is going to sell the pin in its souvenir shop at a symbolic price, and the benefits would be used to organize events to raise awareness about antimicrobial resistance. We are still in the process of finalizing this, but we would like to thank our Swedish colleague, Annette, for your involvement in making this proposal a success. And well, we are building all together a One Health world to reduce antimicrobial resistance, and we are convinced that communication and raising awareness play an important role on it. Thank you.
Okay, now it will be time for a Q&A. So if Jonathan can join us and Richard in the stage, please. Like this, perfect.
In the middle.
Okay, in the middle. In the middle. Yeah, a very small precision about the documentary from BBC and HBO. The title actually is Superbug, but the slogan that the Public Relations and Communication Agency in charge of promoting this documentary would be "Love Our Antibiotics." So just wanted to clarify that. So we are ready for your questions.
Good afternoon. My name is Ivana Detsevich. I work for the European Commission. I have a very simple question. Is it possible, hopefully I haven't missed that on the website, to download the pictures, to print it in high resolution, to decorate our offices, corridors, etc.? Thank you.
Yes, you can. You will find in the website a page explaining how to do it and how to give the proper credits to the illustrators. And this page already includes a proposal for the text, the correct names of the illustrators. So we just, really make the call to use it, but the proper way. Because, there's been a contract signed with them and we must respect it. So they should always be used in the context of the campaign.
And if you need the images with more resolution, of course, contact us and we will send you.
I think there's one there.
Hello, my name's Sarah Earnshaw. I'm from the ECDC, and I just wanted to really say, wow. This work is so beautiful, and it really goes such a long way to capture hearts as well as minds, which I think in this area of communication on AMR in particular and communicable diseases is often missing. So just a huge, huge thank you for all the creativity and the incredible work that you've done. And it's very inspiring. I'll also be printing out some of those sketches to have on my wall. Thank you.
Thank you so much, Sarah, for your kind words.
My favorite question, languages, translations. How is it with the, okay, I love the idea of decorating our offices, which is really cool, but we're thinking of hitting the schools and kindergartens and whatever primary prevention activities. So is it also possible to redub the videos under any intellectual property conditions? How do we go about this?
You mean the videos that we've shown from WOA? Yes, absolutely. Drop us an email and we can discuss it with subtitles. It's always a question of organizing it.
Wonderful, thank you.
Hi, congratulations on all of this. It's indeed amazing. Are you already working on, or do you have plans to let the rest of the world benefit from this? Because of course the burden of AMR is beyond Europe and it's even bigger. Yeah, I'd like to hear your vision on this.
Well, yes, of course. I'll be very honest. The problem is internal capacity, right, to follow everything. As you have seen, coordinating the translations only for the participating countries in EU-JAMRAI 2 has been a tremendous effort. Thousands of emails and exchanges and a lot of organization. But yes, it is possible, and I think that we are always open, absolutely, and it's a question of looking at it case by case and see how much the other part can do, right? Because we can give all the editable versions, and if they keep the burden of coordinating the translations, we could do it. But right now, we also have to concentrate on putting to practice the next steps, the other campaigns and activities that we are going to present you after this Q&A. But if you have ever someone interested in it, feel free to give them our contact and we will of course look at it.
Thank you so much for all of your enthusiasm, dedication. I mean, everything. It's just like she said, Sarah said from ECDC. Wow, very very appreciative all your hard work. And I love that the symbol will go on electronic leaflets in antibiotics. I just want to say that be careful about putting them on the actual paper leaflets, because I think those are black and white, and we don't want to make antibiotics more expensive.
Yes, you're right. We are aware of that, and we'll see how everything. Now we have, this approved, and but then we will see the next steps. I don't know if Antonio wants to add anything. We have Antonio here. He has really coordinated all this effort. She asked after presenting this, "Are we crazy?" So, do you think we are crazy, or do you agree with Ivan? Who referred to this phrase to reply to Anna? Madness is doing the same things and expecting different results. So wish us luck, because we are not sure of everything. We are doing a very difficult thing with long-term results. We cannot do magic to change things in very little time. And that's all. And then now it's when I'm really going to finish. I don't know why. Well, the next slide was to invite you to come to see the exhibition with us after the side events. You have printed instructions on the front desk, and we will also share all the directions with you through the Telegram group. Thank you so much.
Thank you so much, Laura, and all your team. It's always a pleasure, and you all appreciate the excellent work. And I always say, if someday you are in a bad mood, just go back and look at the videos from the communication team, and your day will be full of joy. So that's also a treatment. And so now, to close the day, I'm delighted to call on stage the person who cares of us, the EU-JAMRAI 2 consortium. And this person who cares of us is Ivan Perez, policy officer at the One Health and AMR unit at DG Santé, and he will share with you some success stories. So thank you very much, Ivan, for coming.
Here. Okay. Hi, everyone. Okay, the session today is about EU-JAMRAI success stories. Today we have Markela. She's a microbiologist from Cyprus Health Ministry. We have Michael, that is the work package leader on behavioral change, if I'm not mistaken. And Selma, who is the JAMRAI project leader for Croatia. Yeah, thank you very much. We haven't rehearsed much, so bear with me. We'll try to be as professional as we can, not as much as the colleagues from the work package from communication, that's for sure. But we will try our best. Before we exchange and we discuss about the success stories, let me say just a few words from us, from the Commission. First of all, it's a privilege to be here today. Thank you very much. It's really thrilling. I mean, we have seen these days, 2 days, the amazing work all work package do. Absolutely astonishing. I was talking to colleagues from the Commission, and we are speechless. I mean, it's really, really, really good work. So congratulations, first of all. And these days, these 2 days, we have been hearing about the results from these work packages, and we've been hearing also about the Council recommendation and also the One Health approach that is our architecture, let's say. But before we start engaging, I would like to say a few words or a message from the Commission, which will encapsulate a little bit what we've been saying, what work package leaders have been saying in the last few days. These first 2 years have been an important stage, having the strategic phase of the joint action. We've done a lot of work together, the Commission and the Consortium. We have together, here I need my notes, sorry. Together we have provided the structure, we have generated the evidence in this strategic phase, roadmaps, guidances have been developed. The Commission has provided this strong political framework, which is the Council recommendation. And I mean, very importantly, we have also provided the political support for this incredible joint action. That's not difficult when you have such a great bunch of professionals together. But today we are at the halfway point of this joint action. And this strategic phase is over. We've done our work. The Commission, the work package leaders have done and produced all these tools. And now it's up to you, colleagues. It's up to participating countries and partners to enter the next stage. I think that many people here have been referring to these 2 words, implementation and ownership. I echo the words from Lucy yesterday, talking about ownership, from Marie-Cécile about implementation, but this has been recurrent these 2 days. And this is crucial. I mean, it's very good that we have all these tools, but we have to put them in use. We have to really implement these tools, and we have a budget that we have to spend, and we encourage you to do your best. And why? For 2 reasons. One of them is obviously because of the joint action has to be successful, and today we will discuss about the successes of the joint action. But also because we need this in Brussels. We need your success for political justification. I think that over the last few months I've been talking about this frequently. We are in Brussels in this multi-annual financial framework, which is where we are going to develop the budget from 2028 onwards. And we want to be ambitious. We want to keep up with this fight. We want this joint action to have a new version. We are in the second JAMRAI, but we envisage more. We think that the potentiality is clear, is there. It would be a pity to stop it. But we can do so much, and to do that, we need your support. And for that, again, implementation and ownership, owning these tools is essential. The more you do, the easier it will be for us to justify this need to prolong JAMRAI with our hierarchy. I mean, it's not a given. I don't want to give false hopes. These negotiations are difficult, but the better the justification, the higher the chances. So there you are. I leave it there. Then I want to acknowledge the liaison officers, this figure that has been created by Work Package 5, by the consortium. These are key actors in the implementation stage. And we acknowledge that it's not easy for some of them. These liaison officers are the bridge between the joint action and the national administrations, and sometimes some of them are not fully recognized, or they're in a difficult position, and we will try to work to reinforce this figure. That's quite important for us. And also, there are 30 participating countries and 128 partners. And there are a few leaders that are outstanding, but we have to be all on board. And that's also one of the messages I wanted to give. Is a work that is only complete if everybody participates in it. So please, implementation, ownership, and full participation from everybody. And before we start talking about the success story, sorry, I'm taking a bit long, I would like to share with you a personal anecdote. My background is a veterinarian. I was a clinical vet for a few years. And some of you know that, however, for the last 15 years, I've been working more in EU fisheries policy. So my life has been about the fisheries gear, fisheries quotas, tuna, cod. So about a year ago, I decided to transition to do something different. And being a vet, it made sense, this opportunity. But you can imagine that the transition from fish to AMR is not always evident. And I get this recurrent question, this question from colleagues, especially in Mare. It's like, okay, so how is the change? They laugh a little bit, how do you feel? And I always say the same thing. You know, I'm super happy, and one of the reasons I'm very happy is because I'm part of this incredible joint action that has an impact in society. And this is very true, because sometimes we lose perspective. I mean, I think that the probably worthiest and most important thing we have, the best objective we have in JAMRAI is that we are going to save lives. And this is the reality, this is the core issue. I mean, the value of our work will be valued by every antibiotic we preserve, every infection we prevent, and this will eventually save lives. So this is it. This is the core business, and this is magnificent. This is an incredible task. So without further ado, because I'm taking longer than I thought, and I have this timer that you don't see, but it's, it's scary. I was concerned that I wasn't going to fill out all the time, and I think that I can be talking for 20 minutes. But I don't know, I promise. But okay, we have positive news. Implementation, but this is already happening. And it's already happening, and this is why we talked to some member states, or to all member states, actually Madrid in October, and we threw this idea, like, okay, why don't you give us some success stories that we can already use in this political scenario that we are negotiating the budget, and the response was incredible. I mean, we had around like 20 countries replying, 23 success stories. We have printed some fact sheets that we have disseminated in social media. You can find them also in the info point. The impact has been quite positive. We also have them in our website. And I mean, these success stories, some of them are great, but we have first selected 3. But before I start with these 3 success stories, I think it's important to recognize one particular success story that happened very recently. And I think that Drago probably is around here, is Bulgaria. They have managed to adopt their national action plan, which is, we know how difficult it has been for Bulgaria. This is an incredible success story, one on top of the 3 we have today. And I will start without further ado with Selma, Croatia. These success stories, I will explain them a little bit, and then I will ask some questions. But Selma, you proposed us this super interesting success story. Is about awareness. Has been supported by Work Package 10, our magicians from the communication team. And it's about doing a puppet show for children, and also some workshops for the elderly. It's awareness about hygiene and prevention, and you have also involved the public libraries from Croatia. And the first question is an obvious question, is why you have chosen such diverse age groups, and also the role of the libraries, because when we were discussing to prepare this panel, there was an interesting element about this. That if you can share with us and the audience, that would be great.
Thank you, Ivan.
is recognized as a success story. And our rationale for choosing these two population group as a priority for raising awareness was multi-layered. And first and foremost, we have chosen these two groups because they are very susceptible to infection diseases. Therefore, by preventing infections and antibiotic consumption, which is most prevalent in these two groups, could be decreased, and as a result, antimicrobial resistance can be prevented. Also, our overall aim, our program, was to strengthen hand hygiene and good practices and infection prevention behaviors in both target groups. And our specific objectives were to hand hygiene, respiratory hygiene, and the importance of vaccination. Why we chose the library? Because in Croatia, a network of cities libraries, public libraries, is wide and strong, and it is the meeting point for every ages. And we organized educational sessions with cooperated with kindergartens and schools, and also we organized the educational sessions for elderly people, because the elderly people, their library are the meeting point for them. It's very big impact for social activities in communities.
Thank you very much, Selma. Now, let's talk about Cyprus, Markela. And the Cyprus success story is a very interesting one. It's very different. Croatia is awareness. Cyprus is AMS. You did an AMS masterclass. You chose the 8 biggest hospitals in Cyprus for private and for public. And you collaborated with, you did it through the Drive AMS program with funding from JAMRAI, but also there was collaboration from, or strong collaboration from the health services of the Cyprus Ministry of Health, also from university hospitals from the Netherlands and Greece. The end result, this was a masterclass, but also a training. There were 38 professionals from these hospitals, and the final goal was to develop these AMS project plans, which was very successful. And the question for you, Markela, the first question, hopefully if this ticking bomb that is making me nervous will give us time for more questions. The first question is that there's a strong collaboration between these 3 countries, Greece, the Netherlands, and Cyprus, of course, and together with 8 hospitals. And the question is how this combination of EU support and international expertise help tailor the trainings of these AMS masterclass.
Thank you, and thank you for the invitation to share our success story in this very, very important meeting. So, as you said, the masterclass was organized in a very successful cooperation between the medical and public health services of the Cyprus Ministry of Health, the Radboud University Medical Center, and the the University of Thessaloniki in Greece. And the faculty for the masterclass included experts in antimicrobial stewardship and implementation science from the Netherlands, from Belgium, from Greece, and from Cyprus. Obviously, the participations of experts from the Netherlands, from the Radboud University Medical Center, was crucial.
as this is where the Drive AMS Masterclass was initially developed. But most of the teaching was delivered by our colleagues from Thessaloniki, from the Greek team. And I think this was crucial for tailoring this specific masterclass to the needs of the Cypriot hospitals that participated for two main reasons. First of all, this allowed the use of the Greek language during the course, but most importantly, Cyprus and Greece share similar antimicrobial resistance epidemiology. They share a similar antimicrobial stewardship state. And of course, our two countries have common cultural determinants that influence antimicrobial use. And finally, of course, the faculty also included health professionals from Cyprus, which further facilitated delivering a course that was adapted to the needs of the participating hospitals. As you said, there were 8 hospitals participating. The hospitals were selected by the Cyprus Ministry of Health team. We chose 8 from the state sector and 4, they wouldn't add up, and 4 from a private sector. And we chose not the 8 biggest in the country, but the 4 biggest from each sector. And we believe that it was a successful choice for maximum impact. Everybody was very enthusiastic and accepted the invitation to participate immediately. 38 participants in total, 3 to 5 from each hospital, multidisciplinary clinicians, clinical microbiologists, pharmacists, nurses. And we received excellent feedback from the participants that this was what they needed, this was very useful, and that this will affect and influence their future practice.
Thank you very much, Markela. Beautifully explained. And now it's time for Malta. Michael, thank you very much for being here. The Maltese success story is again different. I mean, it's not AMS, it's not awareness, it's One Health surveillance. And we chose this one because we thought it was a very interesting and different success story. I have explained in my introduction that this One Health is the architecture under which we are working nowadays. And this is a perfect example. This was supported by Work Package 8.4, I think, if I'm not mistaken. And it was a One Health surveillance workshop on antimicrobial consumption and antimicrobial resistance. There were 11 participants, and it's the first time that professionals from the 3 fields meet together. There were a number of conclusions, recommendations, but the first question is, I'm curious about, is about this, I mean, putting together in the same place for a few hours professionals that have never been together before in a space, and what was would you say, the main consensus they reached between these 11 participants from these 3 very different fields?
Thanks, Ivan. Thank you for the invitation. So, as you said, this was the initiative in relation to what was described yesterday in terms of surveillance, use of the EpiCap tool to map surveillance.
Sorry, I forgot to mention this EpiCap tool that I think that was Moria Kelly that explained yesterday, so sorry, that's true.
So basically, you know, we took this opportunity to get together the different actors. Now, this is the smallest country in the Mediterranean. It's literally a rock in the middle of the sea. But like many other instances, you know, communication very often is a challenge. It's a challenge even more because historically, you know, the emphasis has always been on the human health surveillance, where we've been relatively strong. But as a result, the other sectors of the One Health sort of lagged somewhere behind. So this was a great opportunity for us to actually get the people together. And as you said, you know, do this mapping exercise, which was extremely useful. But above all, come up with some consensus approaches. And I think the first consensus was, listen, this cannot be a one-off, it has to be sustained. And as a result, following that initiative, we have now set up a working group within the National Intersectorial Coordinating Mechanism, our National AMR Committee, which has a statutory legal status, and therefore this will hopefully move this forward. The second consensus was that we need to identify what our British colleagues call the low-hanging fruit, things that we can do without major political support requirements. So one of the things we've agreed is that we're actually set up an informal, WhatsApp network where we can communicate with each other very quickly should there be any events or incidents that affect more than one area of the One Health program. And the other thing is that, again, we realize that things are being done. Maybe we can do more, but there's already a good repository. So again, working through the committee, we're working so that hopefully within the coming months, we will have a part of the website of the committee that will have all these surveillance data available publicly for anyone to view, again, as a One Health approach.
Thank you very much, Michael. Very interesting. I think that there is a lesson to be learned from the small island in the heart of the Mediterranean for all of us. It was an incredible success story that we wanted to share, and thank you very much. In that, okay, the ticking bomb has given me more time. Okay, I was sweating. It's like, this is related with the black button, or I don't know. Okay, so we have some time. So, Selma, let's go back to the puppet show and the workshop for the elderly in this setting. It's very interesting with the libraries. But there is another component that is also very interesting about the success story of Croatia. There is a transnational component. And this is JAMRAI also. We know that you were invited by Slovenian colleagues, I don't know if they are here, to their JAMRAI National Day in November, 24th, 25th of November. And we would like to know, the question is about how you think that JAMRAI facilitated this transnational contact, and how did the presentation in the JAMRAI National Day went?
Yes, first I want to mention something, that our children's book are available on website, ECDCF website, and can be shared and used.
Okay, perfect.
Okay.
I'm
English,
sure that we can put this in JAMRAI website.
Yes.
For dissemination, maybe?
Yes.
Or package it, Laura. Stop texting, listen.
And
I'm kidding. No?
Yes, last year, Slovenian colleagues invited us to their national JAMRAI annual meeting to share our activities. And we had a very good and enthusiastic feedback from them, and we are really open for further cross-country experience sharing activities, and we hope that we share our experience and Slovenian colleagues in enrichment of their raising awareness activities. And also we plan to invite our Slovenian colleagues this year for our Awareness Week, Antibiotics Awareness Week, to share their experience in other fields, EU-JAMRAI, example, stewardship, antibiotic stewardship.
Fantastic, thank you very much.
And thank you. We are very pleased that EU-JAMRAI has strengthened our connections with our neighbors.
I think that this is one of the... Thank you, Selma, and thank you for those words, because I think that we are all here clearly thanks to JAMRAI. So, I mean, it's this beautiful network that is connecting people, and we have very positive impacts and tangible results. So, thank you very much. Now the next question is Markela. Again, this AMS masterclass. reading your success story, there's something that was very interesting about the trainers, and is this idea that change takes time, and the trainers in the AMS masterclass gave this example of the bamboo. The bamboo is a small plant that you water and water and water and nothing happens, and all of a sudden it grows. And is this metaphor that I think that the trainers wanted to use for the AMS, that you also started small, and the question goes there, but let me explain. You started with small examples and with trying to make plans of something that it was not too ambitious. And the question is whether you can give us a concrete example of one of these small actions that was developed and then implemented, but as a result of the AMS masterclass.
Let's first explain that about the projects that the participating hospitals had the opportunity to develop during the course, which were based on small goals to begin with. So during the course, essentially the participants were taught about and guided through a step-by-step approach to developing an improvement intervention in their own hospital setting. And this approach consisted of defining a specific antibiotic use problem, measuring antibiotic use in relation to that problem, then analyzing the different barriers and facilitators to improving practice, designing an improvement strategy to address this, and finally developing and implementing the intervention. And of course, at the end, remeasuring antibiotic use to see if the intervention has had any effect. So during the course, each hospital had to develop a specific project plan. They had to present their project plan to the whole group, and they received feedback from the faculty. And as you have said, we don't start big. We are encouraged to have small, realistic goals to, I think it's been mentioned before, to go for the low-hanging fruit. So specific examples of the projects that the different hospitals selected included things like de-escalations to amoxicillin in pediatric inpatients admitted with community UTIs caused by amoxicillin-sensitive E. coli, review of meropenem, 72 hours post-prescription in inpatients at the respiratory ward, and there were a few projects that concerned the implementation of guidelines regarding surgical antibiotic prophylaxis. And it is very important to say, and it was a very good characteristic of the course, that the progress of each project, of each hospital project, is being followed up in webinars up to 12 months after the course. So we are now going to have our last sort of a year after the course webinar in February to see the progress that each hospital has managed to make regarding their own specific project designed for their own setting. But yes, I do like the example of the bamboo. It's an example that's worth giving to like politicians or other people that are eager to seek change. Change takes time, it takes a lot of effort, but you have to be persistent and patient in order to see results. So thank you.
Thank you very much, Markela. I think that we are having loads of very interesting reflections and things that we can use for all of us. These success stories are something to be shared and learn from. And the final question, and then hopefully we will have a few minutes to open the floor to the audience for more questions. The last question is to you, Michael. On this One Health surveillance network, workshop. We've talked about the professionals, but the last question of the panel is about JAMRAI, and how do you think JAMRAI as a joint action and as this network has helped to develop this workshop?
Yeah, so I think there are two elements here. First of all, the availability of the tool. You know, so the fact that you don't have to reinvent the wheel, that you have a validated tool that you can use, is really important. Secondly, well, I would say three, actually. So that's the first thing. The second thing is, and it makes a difference, you know, when you say, listen, this is coming from the Commission or this is coming from the EU, in some countries, not all, but in some countries that has probably more weight than in others. So the fact that this was coming from the outside, you know, they say, I mean, a prophet is never accepted in his own country. So anything that comes from outside is very often looked at quite more positively. So the fact that we had this tool available, that was coming from an EU project, and the fact that the project was actually providing the finances for this. You know, now it didn't cost hundreds of thousands to organize this workshop, but you know, it is still a struggle to get even a small amount of funding in some countries. That is the reality. The reality is, and it's not just Malta. You know, I'm privileged, Diamantis is here, you know, I've been with Diamantis for numerous country visits, ECDC country visits, and we see it. You know, even minimal funding is not there. So the fact that there was funding both for the personnel, you know, to coordinate, and it took a lot of work to do this, you know, hundreds of hours, plus to organize the thing, you know, to have a meeting, to have the venue, to have lunch. That was a really important greasing of this process.
Thank you very much. I think that we have 3 minutes left in this ticking bomb. I would like to open because I mean, I would like to keep talking to you, but I think that I don't know what are the consequences of that. So we're on the safe side. If we open the floor for some questions from the audience, we have a few minutes. So if any of you have any questions for the panelists that probably have more interesting things to say than me, please do so. Marie-Cécile, thank you.
Yes. Yeah. It's quite the end of the 2 days. So, yes, I have one comment and one question, if I may. One comment is what you say about that EU-JAMRAI allowed the connection with your neighbors, the neighbor countries. And I'm very happy to hear that, because it's really also the spirit of EU-JAMRAI too, to make connection within the neighbors. And particularly in these troubled times we have all over the world, I think reminding that Europe is a country of neighbors, is an area of neighbors. Yes, it's very important. And we have also neighbors outside the European Union in the EU-JAMRAI too, as we have other countries, and we have also colleagues from Ukraine, and we are very happy. So I think it's very important. And you know, where I am living in France, there is once a year a dinner of the neighbors. You probably have that also in your countries, and maybe we can say that this General Assembly once a year, it's the dinner of the neighbors, and I think it's a good image. And my question is for you, all three, with your experience, with your success story, have you planned to evaluate your actions with, I don't know, indicators you can have, for example, for AMS? Have you seen already results, positive results for the outcome of what you have put in place? Thank you.
Okay.
Markela,
so in terms of the AMS, I think at the moment, I think it's very early to see actual results in terms of national indicators. So at the moment, what we can see is that for the first time, we have this new, and I have to explain that this was an excellent time for this course to be organized in Cyprus, because antimicrobial stewardship is very, very primitive in our country. In that, until recently, until a year ago, we did not have antimicrobial stewardship teams in hospitals. So just before February, the Ministry of Health decided that it was time really for antimicrobial stewardship teams to develop in Cypriot hospitals, and did make the establishment of AMS teams in hospitals mandatory. So we have limited sort of trained professionals, limited expertise. So this course was an excellent opportunity, and when it was offered to us, we were really excited about it because it was an excellent opportunity to train people that were not involved in antimicrobial stewardship before. So in terms of seeing results, in terms of consumption or national indicators, we think it's very, very early, so we're at the very, very early starts, but it's very, very encouraging to see people starting taking actions, starting thinking about it, and the team starting to operate. So although it's very early to report, in numbers, decreases in anything really, the fact that we're doing something, hopefully we will get to the babu eventually.
And yeah, change takes time, right? So let's be patient because it will happen. So Michael or Selma, do you have any things to say about the indicators or follow-ups?
Yes, I need to share my wish that I hope for continuous and possible extension of GAMRAI.
This is the right place to say it. Okay, thank you. We hear you. Michael,
no, I think yes.
You're asking me for money now?
No. Well, if you have, we don't say no, Malta never refuses anything that comes with. So, no, but I think, it's basically what I said before. So the fact that we now have this established network is, I think, already a good outcome. This networking between us is also very useful. And hopefully, the cherry on the cake will be that repository that we will hopefully be setting up over the next few months with all the surveillance data available publicly for anyone who would like to access it.
Okay, so thank you very much. Unless there are any more questions, I will... No? Okay, so again, please, ownership and implementation, drill this in your brain and daily habits. We have 2 years of work, you and also us, to guarantee the continuation, guarantee the funding, but we cannot do it without you. So please work hard, spend money on the budget,
get results,
and implement all the magnificent tools that have been developed these last 2 years. Thank you very much.
Thank you.
Whoops. Oops. It's the end of the day. I lost everything. I'm sitting out of my chair, so it's time to finish. So, thank you very much. Thank you very much. What a journey. This journey started 2 years ago. And last year, we explored how we could work together and how well we could align. This year, we've seen many new initiatives, tools, and actions emerge. But this is not the end of the journey. But this is the takeoff of our 3rd year, a year in which your collective efforts to bring together science, policy, and society through awareness promises increased sustainability as we safeguard the health of our children and grandchildren. Thank you to all of you for your commitment to all the actions we've seen over these 2 days. And I would like really to thank you all, but also to give a special thanks to the work package and task leaders. You have done an extraordinary job over these last 2 years to collectively lead partners in concrete actions and to build a sustainable future based on sharing practices and solidarity. I know that we at Coordination, we ask a lot of you and that you work hard, very hard. But these 2 days, your work has been honored and you could be proud of yourselves, as I am, proud of you, and I propose you applaud yourself. So before ending, I know that there are excellent restaurants in Vienna. But before having a good dinner and maybe a glass of wine, I would like really take some time to visit the exhibition Skating AMR. It's not far away. You have, just outside the room, you have a paper with a map, all the indication. And some people, if I have all understood, could guide directly you from the site at the University of Vienna. And please, when you will be there, think about all we have said during these 2 days, the perspective also we have for the future and for the next years. The world we are building a safe Europe. And let the images speak to you. Look for 1 or 2 illustrations that tell a story or evoke inspiration for the year ahead. And please, write to us to share your special image and the impact it made on you. We would love to receive your feedback, really. So tomorrow, it's not finished. Tomorrow, we have to work, and we will. The work will be for stakeholders, but also for our leaders and tax leaders. But we will hear the voice of stakeholders. So we start at 9, but we welcome you from 8 if you want. Next year for our General Assembly, it will be in Stockholm, the 2nd week of March. So you can write it down in your agenda right now. And so thank you, Annette. I don't know where you are, somewhere. And thank you for So thank you for organizing the 3rd General Assembly. And really thank you. And I think that these 2 days together, we have shown that we make the power of being one a reality. Thank you very much, and have a nice evening.